So you'll give the introduction, and then I'll introduce the faculty.
So we'll be doing
Okay, we're live. We're live in 5, 4, 3, 2, 1.
Okay,
We're live.
Kishore, can I start?
Yes, sir. You can start.
I think I will introduce myself first. I am Dr. Chandrashekar, President, Karnataka Orthopaedic Association. Good evening, friends and KOA members. On behalf of Karnataka Orthopaedic Association, I welcome all the faculty and delegates to our monthly webinar. I think this is 8th monthly webinar we are doing every month, third Saturday we are doing. Because everybody knows that because of the COVID pandemic, we are not able to meet physically, hence we started this. It is still going on. Today we have chosen the theme, Pediatric Hip Joint in children. We are fortunate to have renowned speakers, experts in the field from various reputed centers across the world. So we have a good speakers from across the globe. Dr. Collin Bruce is a consultant at Alder City Children's Hospital, Liverpool, the current president of the British Society for Children Orthopaedic Surgery. And our friend is still going to give introduction about these faculty still more. Dr. Kishore, consultant from BC Children's Hospital, Canada, he is the research director of the International Hip Dysplasia Institute and currently holds a medical lead position for the Child Health BC Hip Surveillance Program for children with cerebral palsy. He has done a lot of work on pediatric hip. Dr. Prasad is a pediatric orthopedic surgeon from Andhra Pradesh right now. He is orthopedic surgeon at Advocate Children's Hospital, Chicago. Frequently visits the center in Tirupati called Amara Hospital. So we are fortunate to hear his speech on KOA Con in going to Berlin. We had conference in Bellary and we heard his speech in KOA Con held in Bellary. Then I welcome all other stalwarts in pediatric hip surgery to this webinar. I appreciate effort taken by the Dr. Rudra Prasad and Dr. Jayant Sampath to bring them all faculty together to all over the world. We'll have master talks on DDH, Perthes, and slipped capital femoral epiphysis. In between, there will be case discussion by our national faculty. I warmly welcome our national faculty who are doing excellent job in their field. Dr. Rudra Prasad from Indira Gandhi Institute of Child Health and Jayant from Rainbow Hospital, both are senior pediatric orthopedic surgeons. They are concentrating on only pediatric orthopedics. With them, we have Dr. Vidyasagar from Bidar, Dr. Harish from Bellary, and Dr. Sharavan from Bangalore. All are going to conduct this program. Once again, I welcome you all to this program. I thank Dr. Uday Kumar and Dr. Vamshi for coordinating this webinar. And also OrthoTV. I thank OrthoTV for handling the Zoom platform and streaming, thereby helping us reach to audience in wider way. Now I'll hand over the session to our KOA Secretary, Dr. Bharat to share his views. Thank you very much.
Bharat sir, you can mute it, Bharat sir. The mic is in mute.
Yeah, am I audible now?
Yes, sir.
Good evening, everyone. Thank you. Am I audible?
Yes, sir. You're audible, sir.
At the outset, I would like to appreciate the efforts of Dr. Chandrashekar in organizing this monthly webinars on a regular basis. Even through the pandemic, we have got very good response for these webinars. And I appreciate the efforts of Dr. Prasad and Jayant in bringing out this pediatric hip webinar, 3 topics and 3 masters. The 3 masters being Dr. Collin Bruce, Dr. Kishore Mulpuri, and Dr. Prasad Gourineni. They are complemented with our national faculty from all over Karnataka. I am sure they're going to give us a broad insight into all the 3 topics which are going to be covered. It's going to be a useful webinar. Thank you all. Without wasting much time, I would pass it over to Dr. Jayant to do the introduction.
Thank you, Dr. Chandrashekar sir and Dr. RAJU for the kind introduction. Today's webinar is designed for the practicing orthopedic surgeon to be able to make sense of 3 important topics. The webinar will also help to bring some of the insights that our masters have had over the years for the benefit of postgraduates. So it will be a basic level talk by masters. So I think it will be of great value to anyone who's listening. So the reason we have chosen the 3 faculty is that they have dedicated their entire professional lives to the enhancement of our understanding of a particular topic. Mr. Bruce is my colleague from Ddh Children's Hospital in Liverpool. Ddh and Manipal are the 2 places in the world which have the highest incidence of Perthes. So just as our own Professor Benjamin Joseph is one of the world-renowned experts, so also the pediatric orthopedic surgeons in Liverpool, because of the vast pool of Perthes patients that turn up at their doors, week in, week out. Mr. Bruce and his team have acquired a huge amount of experience. In addition, Collin also has a deep interest in teaching postgraduates and in research, and many of his postgraduates have actually gone on to have successful careers in pediatric orthopedics. So it would be wonderful to hear from him. Kishore Mulpuri is one of our own, but is practicing as a pediatric orthopedic surgeon in Vancouver, Canada. He is the current president of the Canadian Orthopaedic Association, which is a matter of great pride for every Indian orthopedic surgeon to have one of our, one of the products of our soil to have attained such great heights. He also has a deep interest in lots of topics, primarily DDH, and he has established a research collaboration called IHDI, International Hip Dysplasia Institute, which is through large-scale multi-center prospective studies is trying to answer some of the most difficult questions in the field of DDH management. Dr. Prasad Gourineni, another good friend of mine, who's the chief of orthopedic surgery at Amara Hospital in Tirupati, has been practicing for almost 30 years in the US, very successfully. He was one of the pioneers in the management of SCFE and hip preservation surgery. So he is another senior voice and an experienced orthopedic surgeon who has dedicated his entire life to the advancement of a particular topic. So I think today we are indeed very lucky to have these 3 masters talking to us about a topic for which they have great passion. So without much delay, I would like to invite Dr. Kishore Mulpuri to give us his thoughts on management of developmental dysplasia of the hip.
Thank you, Jay, for that very kind introduction. And thank you, everyone. Can you all see my slides?
Not yet, not yet.
Not yet? Okay, one second. Let me share my screen. Can you see now?
Yes,
We can.
we can see. Just try to understand that. Yeah. That's
Okay,
fine.
great. So thank you, Jay, for that very kind introduction. As Jay said, I'm an anomaly. I spent 12 years in Karnataka in Manipal. So I would say that's probably the third place where I spend most of my life. Now, officially, I spend more time in Vancouver, Canada than I've spent anywhere in my life. And then Vijayawada, my hometown in India. But the third place where I spend most of my time is in Karnataka. And actually, if you count, probably I spend more time in Karnataka than Vijayawada. That spent my first 5 years of my life. Those of you that know Sarugur in Karnataka, Kabini Dam, my dad actually built the Kabini Dam. So I was brought up in Karnataka till I was 5 years old. Then we moved to Vijayawada, and then I came back to Manipal when I was 18 to do my medical school. And I spent 12 years there. I trained with Benjamin Joseph. I'm still an Indian citizen, even though I'm a Canadian Orthopaedic Association president. So as Jay said, this is really my home. I'm supposed to be talking to all of you from Vancouver, but it so happens on short visit, I had to come to India. So my apologies. I'm going to sign off after my talk and probably the first case discussion. So my apologies in advance for not staying on for the whole course. But it's a great pleasure to be here. And I agree with what Jay said. It's a real honor to share today's symposium with Mr. Bruce as well as Dr. Prasad. And certainly I know firsthand of Dr. Prasad's work and his passion to pediatric hip in general. And I'm going to watch this recording on OrthoTV in due course. So what I thought when I thought about DDH, what should I really be working on? If I start talking about how to do open reduction or closed reduction, I'll be wasting your time, because to be honest, I've learned most of, I think, how to do my open reduction, how to manage late presenting DDH from my mentor in India. I learned a lot of my pediatric orthopedics actually working with Benjamin Joseph. But really, I think where we in India need to pay a lot of attention to is screening, early diagnosis and management to really reduce the late presenting DDH that we see in India. And I think that's where I would say people like Jay and other pediatric orthopedic surgeons that I see here, that in India, whether it's Alaric from Mumbai or Harish that I see on the screen here, they're all putting a lot of effort in. How do we get the word out that we need to really diagnose a lot of these children early and do a non-operative management or probably a brace management? So I think I'm going to focus my talk today on early management of DDH, because I think that's where in India where a lot of efforts need to be. There's surgical management. The rest of the world has a lot to learn from all of you, but not really teach. But I think this is where we need to really work on trying to reduce the burden of late presenting DDH. So I'm going to talk a little bit about terminology and spectrum and what different kind of screening practices there are. And I'm just going to focus on brace management. I'm really not going to go into either open or closed reduction for the interest of time. And we know whether you're talking about dislocation hips or subluxations, there's a wide range in terms of incidence, whether it is 2 to 3 per live births when it's frank dislocations versus a bit more of a milder form of dysplasia. The thing that I want everybody to pay attention to whenever we talk about why is DDH incidence different in different parts of the world, a lot of the time it's because the terminology is different. We're not comparing apples to apples. We're probably comparing apples to oranges. So it's really important for us to think about the spectrum. What spectrum are we talking about? Are we talking about mild dysplasia? Are we talking about a dislocated hip that's irreducible? And sometimes people refer that to as teratologic dislocation. But really, it's important for us to define what spectrum are we talking about. So I'd encourage everybody to be thinking about, is it stable dysplasia? Is it unstable dysplasia? Is it dislocated? If it's dislocated, is it reducible or reducible? Because treatment and its outcome and success rate of different treatments that we do are very different for this different spectrum of DDH. It's important to understand that. And when we talk about screening, you can go from no screening to high-risk screening, right? So, and I would say probably a large part of our country, it is not common necessarily somebody screens and documents. But in countries where I'm working right now, where Collin is, bare minimum, they have clinical screening, and some parts have universal ultrasound screening, but a lot of the Western world has definitely a high-risk ultrasound screening. And we'll get to what evidence do we have as to what kind of screening do we need to do. Clinical screening does not require any money, right? I mean, it's not something that you need to put any effort in. It's something that you would expect everybody to sort of know what to look for, whether it's a midwife or whether it's a nurse that does the delivery, or a family doctor that does delivery, or OBGYN, or if the pediatrician present or not. There are simple things like Ortolani and Barlow tests that you can probably teach many people to do that they should be able to do. That's a bare minimum that we should advocate, that everybody gets a clinical screening. When it comes to ultrasound screening, that, yes, does require some expertise. Now we have handheld probes that are coming out that you could either use your iPad or a cell phone, a lot of people have. Hopefully that'll become mainstream down the road. But for a large part of India still, an ultrasound screening for DDH is not something that's readily available. Even if you have, in terms of inter and intra-observer reliability, is questionable. But if you look at what are we looking at in ultrasound screening, where really most people around the world do alpha and beta measurements, and as described by graph, and some, as described by Hartke, will also do a dynamic exam to see if this hip is stable or unstable. And this is a complicated kind of a classification that takes it from type 1 all the way to type 4. Really, the ones that we are really worried about is type 2B onwards, is what we're really worried about. Do they require treatment? And if so, what kind of treatment are you going to do? Or do they require monitoring? If so, what kind of monitoring are you going to do? Right? Again, as I said, type 2C, type D, and 3 and 4 is really what you're paying attention to in terms of what needs to be monitored, what needs to be treated. And the big question comes, when do we actually do ultrasound? And as I said, universal ultrasound screening, they do ultrasounds at different time points. But if you're one of those that do selective ultrasound screening, that means you're really looking at, is there a dysplasia or not? This really important study from Adelaide, Australia, this actually happened during the time I was a fellow in Adelaide, Australia. This guy, Jacques Riad, who came from Sweden, really conducted this study, and they did 3 ultrasounds in hips that were stable on clinical exam at 2 weeks, 4 weeks, and 6 weeks. And that's when you were able to differentiate apples to oranges. A lot of those hips that were stable for clinical exam at 2 weeks had abnormal ultrasound findings. So I think the best time, if you want to order a scan to look for if there's dysplasia or not, you want to wait for 6 weeks. If you do before that, you may end up with a lot of false positives. You may end up treating a lot of the hips that would probably become normal on their own. Another important study that came up is, what do ultrasound features look like in a dislocated but reducible hip? And if you look at it here, they found a femoral head coverage, if you have roughly about 35% and less, majority of those hips were actually dislocated, right? So it's again an important consideration to keep in mind if you're looking at percentage coverage of those hips. The newer ultrasound techniques, which we use in our center and many others are using now, 3-dimensional ultrasound scans versus 2D, 3D definitely has less variability and better reliability. More research needs to be done to bring this into mainstream in terms of clinical application. But that's coming down the road. And I think you would see these applications coming a lot sooner than we think. Same with a lot of work being done with handheld probes. And we're actually embarking on a study working with POSI and working with Alaric now with few centers in Mumbai and other parts of India to really test the utility of a handheld probe to see if we're able to diagnose, if we're able to acquire automatic acquisition of some of these findings with a web-based app, and more to come on that. Now, coming at X-rays, which most of us that work here, this is how, when I was working in Manipal, when I was training with Benjamin, I was trained to basically look at X-rays. Say the clinical examiner X-rays, there was barely any ultrasounds being done. I'm talking 1990s. I know there's a lot more being done right now. And I'm not gonna go into what you all already know of different features that we look at on an X-ray before we know what the hip rates look like. So some of the key consideration we look at is where, if you can find the ossific nucleus, where the ossific nucleus is in relation to your Perkins line and Helgen-Remus line. And all of us are aware of this classification system that uses, based on the ossific nucleus, where that is, and divides that into grade 1, 2, 3, and 4. But the newer classification system, IHDI classification system, takes into consideration this H point, which is the middle part of your metaphysis, in relation to where your Perkins line and your Helgen-Remus lines are. This is really works well where you don't have the ossific nucleus present. So you can take the Tonnes classification, which I showed here in this slide, and if you compare to this IHDI classification, you can do that without ossific nucleus being present. And this classification system is something I think we in India should really take a look at it. Currently, we're doing some validation studies working with our colleagues from Norway and also colleagues from other parts of Europe that have large databases of ultrasound, as well as plain X-rays, to try and see what correlation do we have between ultrasound and IHDI classification, say in a 2-month-old or a 3-month-old child with a suspected DDH. Now, coming up with this complicated system of classification, this looks like a very complex system, but really takes into what I'm talking about. This takes into account your clinical findings. What are you finding on X-ray? What do you find on ultrasound? And what's your overall diagnosis? Is it normal? Is it dysplastic? Is it subluxed? Is it dislocatable? If it is dislocatable, is it reducible or irreducible? Like how I initially introduced this spectrum, DDH spectrum, it's something to really think about. Those of you that are thinking about giving DDH as a thesis to your postgraduate really need to think about this spectrum. Otherwise, we will not be comparing apples to apples. And a lot of the results, a lot of the variability we see in the literature is we are not defining our classification properly. Those of you that are wondering, look, I'm used to looking at plain X-rays. I don't look at ultrasounds. How do I look at them? It's fairly simple. So if you think about a plain X-ray, ultrasound is nothing but you just have to rotate the image around and take a look at it for you to look at a percentage coverage. And then obviously you have to learn how to draw your alpha and beta angles. As I said, we're working on some algorithms, not only us, there are many around the world. And with web-based apps, you can dump your ultrasound into that, and that'll produce your dysplasia metric with great reliability. Now, I was fortunate with this guidelines that were developed in 2014 and 15 by American Academy of Orthopaedic Surgeons. They had 25 members from 10 different organizations that came together to develop these guidelines. American Academy of Pediatrics, Pediatric Orthopedic Society of North America, AOS, the Sonology Society, and Radiology Society, and many more. And what came out of that is these risk factors. it's important to keep in mind there was lots of traditional risk factors that we were all taught to think about: female, firstborn, full term, Caucasian child, left hip. But really the four that stood the test of time with a lot of literature review is a breech presentation, family history, and the next one is really important. It is called history of instabilities. That means if a GP or if a pediatrician sends a patient to you and say, look, I found this hip to be unstable, that itself is a risk factor. And the last one, what I refer to as swaddling, I'll come to that in a minute, that is wrapping the baby's legs tightly that can produce the hips to gradually migrate out. Let's take a look at what kind of evidence do we have swaddling really produces that. It's not uncommon in Canada with our indigenous populations, our native population that existed before the English settlers and French and others came over to Canada. They would wrap these babies down really tightly, and that they have highest incidence of hip dislocation than any other population. Same with Saudi Arabia, where they try to do the same thing. They swaddle their babies. They have one of the highest incidence. So this is really in cultures where swaddling is prevalent. They have the highest incidence of hip dysplasia. And this recent study done in India also showed that there's a lack of knowledge and understanding about swaddling and swaddling practices producing hip dysplasia, hip dislocation. So if you all think about it, we used to call DDH as CDH, congenital hip dislocation of the hip. And swaddling is a perfect example where it is a developmental dysplasia. For all you know, these hips were normal when they were born. If we wrap them too tightly, those hips can gradually go out and sublux and dislocate. This study done out of Mumbai by Elric Ajuris and Rujuta, it's published in Indian Journal of Orthopaedics, showed there's very little knowledge and understanding among the caregivers or the nurses or the pediatricians about swaddling being a risk factor for DDH. And not much advice is being given about safe swaddling practices where the hips should be kept in abduction. For example, what you see here is where you've swaddled the upper part, but you left the bottom part where the hips are still abducted. Here is a child where the entire body is swaddled together like a burrito, right? And that produces the hip to sublux with time, right? So swaddling appears to be a deeply rooted practice in some parts of India, and a lot needs to be done in educating our colleagues about swaddling practices. Coming to what screening is required based on either AOS or Cochrane, and I think the conclusion really is there's no evidence in a country like ours to advocate for universal ultrasound screening, which it costs a lot of money. We don't even advocate for that in Canada. So what we do is selective ultrasound screening, but a universal clinical exam in all the children that we see, right? So key messages when it comes to screening, all neonates should be examined, and the risk factors need to have a ultrasound screening in addition to that between 6 to 8 weeks of age. Now, what do we do at 6 weeks if we do an ultrasound, if it's either normal or we find mild dysplasia? And this study that's done out of San Diego showed the hips that were normal at 6 weeks, there's roughly about 30% of them that turned abnormal on X-ray findings at 6 months. So they recommend routinely doing an X-ray at 6 months in these risk factor population. If they have either family history or they have history of instability or breech presentation or known swaddling, you definitely want to get a minimum 6-month X-ray. Here's an example of how sometimes your ultrasound and your X-rays may not correlate with each other. Here's an example of this ultrasound, which looked pretty good, both on the right side and the left side. If you did an X-ray around the same time, you can see that X-ray, that hip on the left side, looks a lot more dysplastic than the right. So it's really important that we do get an X-ray at 6 months of age, because that's what we follow beyond that age group, right? So what do? I know it's a bit of an overkill. I actually get an X-ray done at 12 and 24 months, and we do that mainly for research purposes. I'm not recommending to all of you that's what we do, but that's our current practice. But I would recommend a bare minimum getting an X-ray at 6 months. And what do I do with Barlow positive hips? That means these hips are subluxable, but they're actually in. If I have to push the hip to go out, I personally don't treat them. Those are controversial areas that require more investigation. But if the hips are dislocated, they're either reducible or reducible, I personally would treat. But if they are in, I have to use force to dislocate them, I don't treat them. But I fully understand why my colleagues around the world may want to treat those hips. What kind of treatment? You can go either with brace treatment, closed or open reductions, depending on the age, and more involved surgery. But I'll stick to just a brace treatment for the next little bit of our talk. There are lots of different braces that are used. The most common brace that's used is a Pavlik harness for young children. And then the big question comes is, do you use a soft brace like a Pavlik harness, or do you use a more of a rigid brace like a Dennis Brown or a Reiner Cruiser? So most commonly used brace around the world is a Pavlik harness. That's certainly what we use in Canada. Lots of US and majority of the parts of the world uses Pavlik harness. And you really have to check for femoral nerve palsy, especially in a dislocated reducible hips. It's not uncommon for them to have. And you want to continue to see how those hips are doing. If in 3 weeks, if this hip is not stable, often you discontinue and think about what your next steps are. And this study published with our large multi-center study showed 79 to 80% of the hips that you could actually probably treat them effectively with brace treatment. And what are the factors that can predict failure? Is severity of the dislocation, the older the child at the initiation of brace treatment, the type of brace used. There's some soft evidence that more rigid the brace is, the better effective the brace is, and whichever hip that's most resistant. And here is an example of a 6-month-old that presented with a dislocated hip that was put in a Pavlik harness. And you can see this hip at 11 months of age, gradually stabilizing. At 3 years of age, just purely with the brace treatment, even though this kid was diagnosed at 6 months, still did really well. So I would say the first line of treatment, if you could do it and you have access to it, you should start doing with the brace treatment. Here's another example of a 6-month-old that again had a brace treatment and continues to have at 14 months of residual dysplasia. And if Pavlik ever fails, obviously you go on to doing either closed or open reduction, right? So what do you do if Pavlik fails? You really have 2 options. Either try more rigid brace. That's what people do. There are lots of studies that have shown that they can have a more of a success with the rigid brace versus Pavlik. And if that fails, they go on to closed reduction. And I have to say, in my own hands, I have not been able to replicate this success that some of these investigators have done. And this study by Dr. Shankar and from Children's Hospital Philadelphia, they use a Ilfil brace, and they showed their results with a failed Pavlik with Ilfil brace was as good as a closed reduction. Mind you, this is not a randomized controlled trial, so you have to take some of those results with a pinch of salt. Now, what do we do with irreducible hips? Even with those, again, this is published out of IHDI, and we showed still the first line of treatment is using a brace treatment. But the success rate is a lot less compared to a reducible hip. There was almost 80% here, you have 60% success rate. That's why I stress upon the point again, you really need to define the spectrum of dysplasia that we're talking about. What about femoral nerve palsy? Femoral nerve palsy is not uncommon. Obviously, if you look for it, you find it more often than if you're not looking for it. And we have looked at it as a part of this registry of our International Dysplasia Registry. And the incidence is actually not uncommon. So we have about 5.9% of the population that was treated with brace treatment that had femoral nerve palsy. What do you do once you find femoral nerve palsy? Personally, for me, I abandon the brace. I try to put them in a more rigid brace, but probably not flex the hips as much. And I would say it's a surgeon preference what's done next, as opposed to any real science, whether you should abandon the brace altogether, do a closed reduction later on, or whether you should try more of a rigid brace. So it is an underestimated complication. There's a huge practice variability, and it's surgeon decision-making that dictates the management and treatment outcomes. I don't think there is any scientific evidence right now to recommend one versus the other if you do find a femoral nerve palsy. And those of you that are interested in where are we at with this study, this was our last update that was published in 2018 that gives a great summary of where we're at with some of the prospective evidence for development dysplasia of the hip. And as the saying goes, lots done, a lot more to do. I would say we're just scratching the surface right now. We hope that in the next 5 to 10 years that we would be able to shed more light on some effective treatment strategies and with comparative effectiveness research. And so we now are leading this global research with International Dysplasia Registry. 5 centers from India are part of it. And from Karnataka, we have Manipal as one of our contributing sites. They're in fact one of our biggest contributors to our registry. And we have recruited 4,000 patients, and these are 4,000 fully dislocated hips of different ages. And this is the one that I want to draw your attention to. And what's being entered by the developed world of Western countries is rough mean age of presentation is about 4.7 months. But the mean age of presentation of these 5 centers that are entering data into a registry is almost 31 months. And I think this is where we need to pay attention to and put efforts in India. How do we reduce this walking age dysplasia so we can diagnose and treat these conditions much sooner? And one thing that I would say is, in general, for DDH, if you're doing either closed or open reduction, if in doubt, it's out. If it's out, then you really have to really relook at that hip and escalate it to a higher degree of management. And I'm incredibly proud of how well during COVID, like how I've heard that you're doing webinars frequently, and Pediatric Orthopaedic Society of India embarked on this guidelines development DDH. We had the good pleasure from Canada of facilitating and helping. And Divi's Foundation for Gifted Children from India is actually being one of the main sponsors, along with I'm a Hippie, which is a nonprofit from Canada that supported these efforts. So the combined membership of these organizations that you see that was involved in POSI DDH care pathway that's just developed and being published right now. And I think that's the way forward to bring light and attention to this problem so that we could continue to work on reducing the walking age dysplasia in India. Thank you so much for giving me this opportunity.
Thank you, Kishore. That was a lovely talk, and it really highlights some of the issues that we have in the management of DDH. If we want to make a real difference in the lives of children presenting with DDH, I think it is to try and detect and diagnose DDH early, and to start the treatment as quickly as possible. Dr. Shravan is our pediatric orthopedic surgeon from Ramaya Hospital. He has a couple of cases, and then if there is time, I'll follow up with a couple of cases of my own. So Shravan, if you could share your screen. And
yes,
then start the discussion.
Thank you, sir. I'm starting to share it right now.
Yeah, Shravan is sharing his screen. I have one question for Dr. Kishore.
Yes, sir.
You were mentioning about this femoral nerve palsy. How do we recognize in these small kids?
Yeah, I think normally what I do is when children come, I tickle their feet and you see the knee kicking. And if you don't see that and there's like a limp limb, and then you know that quads is not working. So then what I do is I take the pelvic harness off from both feet, both legs, and then I just leave them in the clinic for about 20 minutes. I go back and do the same. And if I have one leg that's really kicking, the other one is not. And that's how you diagnose it. So it's not one of those where, you know, and you can test with EMG or whatever. It's one of those where you just need to observe the child for a bit, have a little bit of patience, teach the parents about how to look for it, and then take it from there.
If I can just follow up, how long, what is your average time in harness for your typical DDH?
Yeah, so Jay, depending on when I diagnose them, and if I see a child, say at 2 weeks, typically I used to go to nursery and see all babies with possible dislocated hips. I don't do that anymore. I let the family bond, and it's more important for mother to breastfeed and, you know, deal with that anxiety of this newborn child than me going and examining, putting a child in a pelvic harness. So I never put any more day 0, day 1 pelvic harnesses. We bring them back to clinic at about a week to 10 days. And a lot of the time, the so-called unstables have actually stabilized a little bit, right? And if I'm treating them at 2 or 3 weeks, typically most of them between 6 to 8 weeks, and I do an ultrasound at that time. If the hip is completely normalized, I don't continue the brace. I wean it off within a week or 2 weeks. But if the hip is still looking dysplastic, then I continue for another 6 weeks, and then I get another ultrasound done. And then based on how it looks, then I gradually wean that off. And this is where, when we talk about art and science of medicine, I don't think there's any one good rule of thumb, but I don't actually brace them for months and months. You know, this thing where people say, you know, time of diagnosis ×2, I don't believe in that. If the hip is normal, it's normal, and then I discontinue the harness.
Okay, I would just add to this, to Kishore's point. As you know, in Ddh, we put them in a harness. They're usually in it for about 2 months. Once it's normal, and there's no point in keeping it in the harness any longer. And we don't even wean. We just take them out of the harness when it's normal. And in the however many years I've been there, maybe 20 years, we've never had a patient come back with a failure after not weaning. So I know a lot of people around the world, certainly even in the UK, wean. We just don't wean.
And do you use a rigid abduction brace in case of pelvic harness failure, or you proceed to closed reduction?
So no, in our it depends. So it depends on what you mean by pelvic harness failure. I mean, a proper failure where it doesn't go in properly, they go in for closed reduction. If you're talking about a patient who kind of gets too big for the pelvic harness, but the hip is still located and perhaps a little bit subluxable, then a rigid harness would be appropriate, because it doesn't need to be put back in. It just needs to be nurtured while the dysplasia goes away. So we do sometimes, but proper failures, like 2 or 3 weeks where it doesn't go in, no, they go straight for an arthrogram and potential closed reduction.
Yeah, I agree with Collin. I couldn't replicate some of the results that other people have talked about. And for me, I've tried in few, but, I have not been able to replicate failed pelvic to a rigid brace. I basically tell the family, if it's at 6 weeks, either I do a closed reduction right away, or I tell them to come back at 4 to 5 months where I can do closed/open reduction. Because we do know at that age, 90% of them at age 2 months to 2.5 months to 3 months will be closed reductions. So,
okay. Kishore, might I ask you we don't offer traction in the UK anymore. We're not talking about this age group, slightly older children, and we don't offer traction. It's not been offered for many years, and I know in the United States they don't, and it's related to insurance. But I know that in some of our neighboring countries in Europe, they do use traction a lot for this group of patients. And I try to encourage my colleagues to kind of reevaluate this, because in a way, if the hip can go back in closed rather than open over a period of time, it seems to me that it's like a Ponseti approach rather than a a surgical treatment for clubfoot. If you can do that and it works, as according to some of our French colleagues, it seems like a good idea, but I don't know whether you have any experience or see anybody in the United States or Canada doing that.
No, I mean, Collin, I think that's a great comment. Yeah, if I see a 12-month-old for the first time, I started my practice with routinely doing traction to now just talking to the family about probably how practices vary in different parts of the world, and then offering that to them. And my practice for 18-month-old has grossly changed over the years, where 18-month-old, where I'd go in, I'd do just a closed or open reduction, do a different operation to doing a pelvic osteotomy to now doing a lot of that at once. So I think in general, my want and desire and belief in doing traction has sort of waned off over the period of time. But I fully understand that there are parts of China now and Japan have shown where multiple weeks of admission to the hospital, traction over a period of time, actually reducing and doing that as a closed treatment. But challenge
and then maybe,
challenge
and then maybe do a pelvic osteotomy after it's gone back in.
Exactly right. So I think where the problem comes is with, especially when a cost of one night stay in Canada is more expensive than for surgery. Like say, if it costs about $4,000 as a surgery fee, one night stay in the hospital is $4,000. So if you're keeping someone in the hospital for 10 days, the cost is way more expensive than doing actually a surgical treatment. And especially if you need to augment that with some other surgery later on. So I think traction as such is fallen out of favor gradually over a period of time.
But based on the economic evaluation rather than a proper randomized control trial of whether it works or not.
Yes.
I mean, in India, inpatient stay, particularly in a public hospital, is not very expensive. So in a place like Indira Gandhi Children's Hospital, where Dr. Rudra Prasad works, I don't think it would be very expensive to hospitalize a patient for even 2 weeks if we can show that it reduces the overall complication rate, if there is some additional clinical benefit to using traction as opposed to more invasive means. But I don't think that argument has really been settled one way or another.
No.
I agree.
And it does need to be settled, and perhaps Mr. Perry should come and speak to you guys, because India sounds like a place that it can be answered, because it won't be answered in the United States or in the United Kingdom now, because the money's too powerful.
So, Dr. Prasad, any comments?
No experience with traction. I'm from the US, so absolutely no traction for us. I do brace them longer than the other two speakers. I don't see a downside. So as long as the mom allows me to continue the bracing, I do brace. I don't see them often, and I don't see any complications by continuing the brace. I don't give them a new brace, but once the old brace wears off, they stop wearing it.
Thank you. So Shravan, if you'd like to go ahead and start with your case, please.
Absolutely, sir. Good evening, everybody. I'm Dr. Shravan from Ramaya Hospitals, Bangalore. I'm a pediatric orthopedic surgeon here. One of my highlights of my fellowship in Mumbai Vario Hospitals was collaborating with Dr. Kishore and his research assistant, Emily Schaffer, in preparing the IHDI in 2017-2008. That was when we started off with Dr. Alaric. Pleasure being with you in this webinar, sir. And in the first scenario, we have this case by a panicked obstetrician who calls and says that there is this kid who has bilateral CTV under her unit. And this is what it shows. There's a newborn baby with obvious deformity of both the lower limbs, full term, LSES, unremarkable antenatal history, and the non-consanguineous marriage. On examination, we see bilateral CTV, yes, and on further examination, it's an autolony positive bilateral DDH as well. And I go ahead and get an ultrasound. Dr. Jayant has a publication in 2010 in JBJS with association of CTV and DDH. What are your comments, sir? Yeah,
that's actually a thing that I actually did with Mr. Bruce and Dan Perry.
Yes.
And we showed that there was a 10 times higher risk of DDH if there was CTEV. But that's only because the incidence of DDH in the general population is 1 in 1,000. And out of 100 children with CTEV, we found 1 DDH. So that's like 1 in 100. So, but there are several other studies which refute the association. So I think we need much larger sample size. You need tens of thousands of patients with CTEV, and then you need to do a long-term randomized, sort of long-term, sort of longitudinal study to really answer the question. But our practice right now is that all children with CTEV do get a hip ultrasound scan at 6 weeks. So that is our current practice because it's a very simple and easy thing to do.
Absolutely.
Yeah.
Dr. Kishore, what would we start treating at this point?
Yeah, I think this is a really important one to understand. So I want to know, I mean, obviously these knees can be flexed, and I want to see how much abduction there is. Are you able to reduce these hips back in, right? And what's going on with this child? So if you can abduct the hips and if you can flex the knees to 90 degrees, and honestly, it's a dealer's choice whether you want to use a brace treatment versus actually you want to tackle the club feet and knees first, and then before you go on to hips. Certainly, if you're able to abduct the hips and you want to start with a brace treatment, you can. But if somebody says, look, I want to take care of the club feet first and want to make sure the knees are okay and then deal with DDH later with a close reduction, and that's fine too. So it's really dealer's choice as to how you would deal with it.
So I did something concurrent sort of a management where I started casting and I put the patient on a brace as well. And after I gave a proper trial of a Pollock harness, and we finished it at 6 weeks. We've braced it completely at 6 weeks, followed up every 2 weeks with the ultrasound, and it was quite reducible in the ultrasound. And post the 6 weeks trial, we started weaning off, and we got an X-ray done at around 4 to 5 months of age, and this is what the X-ray shows. Any comments on the X-ray, sir?
Yeah, the X-ray shows that the hip is still out, right? I mean, it's if you're looking at probably an IHDI kind of a grade, and this is a bare minimum an IHDI grade 2.
Yes.
And so you really have to still, you got to still get this hip to go in.
So at this point, I went ahead and did a close reduction arthrogram and a hip spica application. Any other options, or would that be right?
Yeah, I think, that would be right, but I'd be warning the parents that there's a high degree that these kind of hips may not go well with close reduction, and they need to be prepared for either an open reduction at a later date, depending on the age of the child now. How old is the child now?
The child is about 5 months of age. 5
months, yeah. I wouldn't hesitate if my close reduction fails at that time. I would go ahead and do an open reduction, even though some people talk about this ospic nucleus present or absent, and I wouldn't pay any attention to that, because that research, when we looked at the large multi-center study that we're talking about prospective with IHDR, we found that initial observation made from Southampton really didn't hold good, that waiting for ospic nucleus to appear for AVN and no AVN.
Shravan, I would add that I would agree with that. We don't, in Liverpool, we don't wait for the ospic nucleus to appear, just because the evidence in favor of doing so is weak, and while you're waiting, you're just allowing more and more dysplasia to occur.
Absolutely.
The other thing that I would add to it is that you have to trust the ultrasonographer if you don't do it yourself, because they've called it a type 3, but the key difference really in the graph system between a type 3 and a type 4 is whether the labrum is infolded or not. So a type 3 really should go back closed because it's just subluxed and the labrum is everted and it's inviting the hip back in. But if it happens to be a type 4, and we've reviewed our type 4s, and there's a very high chance that you won't achieve a successful closed reduction with a type 4 ultrasound. And the reason that it won't go back in is because the labrum's infolded.
Absolutely, sir. Yeah, you're right. And so I went ahead and did a closed reduction arthrogram, and I just skipped to the arthrogram now. We did a closed reduction of arthrogram of both the hips, put the child on a spica, and thankfully the child's hip is reduced and good till now. So this was just introduction to a polyc harness in the closed reduction. We just go with 3DH through the ages.
Just if you go back to your arthrogram, just to add a little bit of controversial discussion, I'm not sure that that is properly reduced because the labrum is infolded. The hip is resting on an infolded.
I'll just play it back in again. Yeah.
And you've got a lot of medial dye.
Yes.
So I think that there's an infolded labrum there
at this point.
Yeah, because it's not really seating to the floor of the acetabulum. Now, some people will accept that and expect that over time that it might actually dock because it will make the soft tissues conform. So there are, and I think that I forget where I read it. There's a I think it's Japanese study showing that sometimes this does come out of the way because of the pressure of the femoral head. But our worry in Ddh is that if we have a hip like that, that pressure might ultimately result in avascular necrosis. And so our approach to an arthrogram that looks like that would be to do a medial open reduction in that age group.
Absolutely. So I didn't do a medial open reduction. The child is about 1 year and 6 months at present.
Yeah.
And keeping your pointers in mind, I'm going to keep a very close watch on this child's hip.
Yeah.
Yep, absolutely. Thank you, Dr. Collin. Let's moving on to the second case. We have a 1 year, 5 month old male child. He presents at 1 year and 5 months. He's full term, breech presentation, LSES. The hip at presentation is dislocated and irreducible. The flexion abduction is 40 degrees at a limb deformity of 1.5 centimeters and has a Trendelenburg gait. This is a pre-op, IHDI grade 4, a stapler index on the left side of about 40 degrees, and the ossific nucleus is absent. So we have an AP view, we have a frog leg view, and we have an abduction internal rotation view. So this is a 1 year and a 5 month old child. Any comments, sir? What do we go ahead?
Yeah, I mean, look, as I said, olden days, if I was training in Manipal during 1990s, we'd bring this kid back in, we'll put the kid in traction, we'll bring the child for probably a closed reduction if it worked, and you would put them in a cast, come back in later on. A lot of them will still have residual dysplasia, and you may do a pelvic, whatever you need to deal with at that point in time. But 1 year, 5 months, 1 year, 6 months, 18 months, the same. I would go in still hoping that I can do a closed reduction, but a lot of them in my hands will end up with an open reduction, possibly a small amount of shortening, but a lot of the time derotation. I've got x-rays where I've done, I get somebody to take a picture with my iPhone where it's not really the shortening, but they require a lot of derotation to keep the hip in. And so it's not uncommon to do that. And sometimes I have to dial in a little bit of extension so to get the anterior part of the femoral head to go in when I'm fixing that. And I don't hesitate to doing especially if I've done an open reduction, anterior open reduction, I would do a pelvic osteotomy at the same time, even though they're young. I've gone from, trained with Benjamin, very rarely done, pelvic osteotomies to now do them younger and younger. So I've done at 18 months, probably sometimes even a little bit younger.
Collin?
Yeah, I would take very similar approach. I've gone from training with Tony Cattrall and doing an anterior open reduction, and then sometime later doing a derotation osteotomy as a second procedure. Moving forwards to now, for a child like this, we would do a open reduction, always combine it with a pelvic osteotomy because the pelvis is not normal. And if it needs shortening, which it often doesn't, but if it needed shortening, we'd combine it with modest rotation, but varus, because the varus changes the biomechanics and it will further encourage acetabular development. So kind of similar approach, actually similar history, similar background, similar approach to Kishore, more and more invasive.
Yeah.
Dr. Prasad?
I rarely do pelvic osteotomies at this age. I usually wait till 2 years of age, but I plan on doing femoral shortening and I do put a little varus every time.
Why do you wait? Whereas Dr. Kishore said that he would not hesitate to do pelvic osteotomy even at a younger age. Is there a reason why you wouldn't do a pelvic osteotomy at a younger age? You'd wait?
Yes, the iliac bone for me is not for I do a conversion often. With the bone graft, the iliac wing may be too flexible. I can supplement it with a pin if I need to, but I need to see the iliac bone to be strong enough for me to do a conversion. And I believe that the younger patient probably will remodel better than an older child.
I think that's a fair comment. I think that's a fair comment. So my threshold for doing it, because one of the questions our trainees often ask is, well, why don't we do that to younger children? Because our threshold is about 18 months, and that is simply because I have done pelvic osteotomies in younger children, not for DDH, but for things like bladder exstrophy, and the bone is wafer thin, and you can't get a wedge in, and it doesn't really work. So our threshold is 18 months. If somebody comes along at 15 months, I'll just wait until they're 18 months and do it then. It's kind of arbitrary, but that's what we do.
So,
Right.
Shravan,
Yeah,
go
right.
ahead
So,
and tell us what you did.
so we didn't do an arthrogram. We did an anterior approach. There was no acetabuloplasty done. We weren't as aggressive as we should be, most probably. We did a derotation osteotomy, definitely of 20 degrees, and an adductor and the psoas release. This was immediate post-operative. I'm just going to show you the follow-ups at 12 weeks, at 3 months, 6 months, and 9 months. So this is the final follow-up as of now. So we see that the ossific nucleus is developing, and the acetabulum is becoming shallower. So
Deeper.
Yeah, deeper. Yes, pardon. Yeah. So would we still have offered her acetabuloplasty at that age, or did we do right retrospectively?
Yeah, I think, Shravan, I would say I would have done a pelvic osteotomy. As Collin said, look, this is what happens, right? You train with Alaric, you learned a certain way. When you lose more hair, like me and Collin does, you will, Jay, you will have your own way of looking at and going, where I'm at, right? So I would say, I think for me now, I would do it. If there's one thing that I can stress upon between doing femoral shortening and derotation, it's the derotation that you really need to be thinking about, right? So rather than shortening. So I'd say, look, this is great, but I would do anyone at 18 months, I would be thinking about doing pelvic osteotomy at the same time, because our ability to accept residual dysplasia is probably a lot less than what it used to be, right? So for me, this is a great result with what you've done. I don't think there's a right or wrong answer, but in my hands now, I would do at the index operation, I do a pelvic osteotomy.
Yeah,
Right.
Me too, for the same reason, because I've got lots of patients where I didn't, and then you think, why didn't I do that? Because at the time you do an anterior open reduction, adding a Salter osteotomy or a Pemberton or whatever your preference is just an additional 10 minutes. It's really nothing.
Exactly right. Okay, so I'm sorry, I have to go. I told Jay, I really appreciate being here, and I'm going to watch. I think I'm going to listen to Collin and Prasad give their talks. It's a real pleasure to be in India to do this. And as I said, Karnataka is my second home, and I'm actually in a house of my uncle who's also done his pharmacy in Manipal. And those of you that are thinking about who that is, that's Divi Lab. So my youngest uncle is Murali Divi. That's whose house I'm in. Cheers to all of you. I'm enjoying a little bit of scotch. So, right, so thank
Have
you.
a lovely
evening.
Yeah.
Thank you.
Thank you.
Kishore.
Thank you so much, Dr. Kishore.
Okay.
Bye-bye.
Thank you. Thank you. Bye-bye.
Thank
Bye-bye.
you.
Thanks.
So
Thank you, Dr. Jain. I'm done
Thank
with
you.
my case presentation.
great. So if we can move on, just unshare your screen.
Yes.
Raman. I'd like to invite Mr. Bruce to follow on with his talk on Perthes.
Okay, let me share my screen. I'm not muted. That's right. Share screen. That one. And how's that?
Yeah, perfect.
Can you see? Okay,
Yes.
good.
Very good.
So I shall try and whiz through this quickly. I'm quite good at speaking fast. So I've called this lecture, I give this to our course annually, and it's been amended a little bit. What do we really know about Legg-Calvé-Perthes disease? Okay, so we're going to talk about these. What is it? Who gets it? Why does it happen? Are the classification systems useful? Because there are many. And I'm also then going to describe to you what our management philosophy is towards it. It's a way of thinking about Perthes disease. So this is the best description of Perthes disease ever, and it was written in 1913 by Perthes himself, and it is that this disease is a self-limiting, non-inflammatory condition of degeneration and regeneration. And that, I think, is what separates it from what can happen to the adult, because in the adult, when they get avascular necrosis of unknown etiology, it often doesn't regenerate. And so children have got this power to regenerate, which kind of makes it a separate condition. Of course, it's not called Waldenstrom's disease, even though he found it before Perthes, Legg-Calvé, because he thought it was tuberculosis. But his contribution really is identifying the pathogenesis of what happens on the x-rays from initial stage of sclerosis, then fragmentation, reparative, and then ultimately healing the regeneration. So who gets it? So this is a difficult question to answer to this audience, because who gets it in the United Kingdom is it usually occurs between 3 and 12, but for us, the kind of peak age is about 5 to 7. And I know in India, it's somewhat older. It's bilateral in a small percentage of cases, and it particularly affects boys, 3 to 5 times more common in boys than it is in girls. And why that should be is anybody's guess. The epidemiology of this, the reason I've got a bit of experience in it, is because actually we beat Benjamin Joseph, because I think the highest incidence that they reported was 14.8 per 100,000 cases. And in Liverpool, back in the 70s, the paper was published in the 80s, but all this data was from earlier on. The incidence was a little bit higher than that. And so it's common in both of our countries. In our setting, it's an urban disease, because in the United Kingdom, most poverty exists in inner city urban settings, because the rural parts of England are populated by rich farmers and rich landowners. Whereas in your country, I understand that it's mostly rural, because actually that's where more deprivation exists rather than in the cities, although no doubt plenty of deprivation exists in everybody's cities. However, in Liverpool, and when I think I started work as a consultant in somewhere here in the mid-90s, and one of the things that I encountered when I was starting my work is, oh my God, all I'm ever treating is Perthes disease. And then gradually I began to notice, oh, it's not quite so common, and none of my colleagues were treating Perthes disease. And my predecessor, John Taylor, who Benjamin Joseph worked with when he was doing MCH, had done all this work in the past, showing that the incidence was very high. And so I got a fellow, Dan Perry, now a national NIHR professor, to do this work with us. And what he showed was what I knew, and that was that, well, the incidence continues to fall. So something in our environment has changed, and this disease is becoming less and less common for us, at least. It's also, if you look at twin studies, the twin studies show not very good correlation between identical twins. And so again, it kind of supports there being some kind of environmental trigger for this in a lot of the patients. Following on from the work that we did locally, we looked into the GPRD, which is the General Practitioner Research Database. So it's the biggest database in the world, looking at the entire country. And but it doesn't look at every general practice. It looks at selected ones around various areas. So from that database, we collected 760 patients with Perthes disease in 1 year. And what we showed was, again, over time, looking at incidences across the UK, the incidences, looking at various papers that have been reported, the incidence across the UK as well is falling. So this is the disease that's disappearing quickly, really, for us. And the main finding in most of the patients who have it versus the ones who don't is they are all more socially deprived, more poverty, less money. Probably, is it nutritional? Is it exposure to something? Who knows? So why do they get it? So we all know that the femoral ossific nucleus and the femoral head in children has a very tenuous blood supply, kind of end artery supply almost, as it were, from the medial femoral circumflex and this lateral ascending artery. And so it's kind of vulnerable. So that's why they get it, because this blood supply gets disturbed. Is it an arterial disease? Is it a venous disease? Or is it both? Or is it because they've got abnormal vessels? Is it because they have abnormal coagulation? They like to clot too much. They don't break down their clots enough. All of these hypotheses have been put forwards, and there isn't really a winning answer. And maybe all of these things occur. Maybe it's a multifactorial condition that ends in a common pathway, because of course children with sickle cell disease end up with a condition that looks very like this. Children who get treated with steroids end up with conditions that look like this. So, but quite what the pathogenetic trigger for Perthes disease is unknown. You all know how it presents. So it presents as an irritable hip, and then your differential diagnosis excludes other things, and you end up with a diagnosis of Perthes disease, either because you can see it on an X-ray, or if you can't see it on the X-ray, you can see it earlier on a bone scan or an MRI scan. So here's your typical X-ray of somebody with Perthes disease. Now we move on to the classification systems. And so there are 6 at the moment that you can use for Perthes disease. And are they actually any use? What is the point of all of these classifications? So I'll go through my thinking about where the classifications are, and certainly some of the mistakes that our trainees make in understanding what they're for. So Waldenstrom described the pathogenesis of the condition, and the Elizabethtown classification, which I know, in fact, we never use this. I know that Benjamin Joseph popularized this, and my attitude to it is that if you have a classification, then the more categories that it has, the more inter and intra-observer error there's going to be. So actually giving somebody an accurate Elizabethtown classification, very difficult. It was devised by Terry Canali in Pennsylvania. Its only usefulness, and indeed it's an advanced version of the Waldenstrom pathogenesis, is that in the early stages of fragmentation, this is where early managements like containment are appropriate, because the femoral head is still plastic while this is happening. And if you change its external environment, you might be able to mold it into a better shape. However, once it starts to heal and it gets into the reconstruction, the regeneration, and certainly the healed stage, containment is not appropriate, because you cannot change the shape that femoral head is going to come, because it's already decided and it's on its way, and nothing you can do can change it. So these classifications are quite helpful, retrospectively applied for research to see how patients did if they finally ended up in whatever stage they did, but they're not particularly useful for helping you to decide who needs to be treated and who doesn't. Cattrall's classification is much the same. So Cattrall's classification, if you read it, is complicated. I simplify it for our trainees to say, actually, it depends on how much of the femoral head is involved in this avascular necrosis process. So the front quarter is group 1, the front half, group 2, the front 3/4, group 3, and the whole thing, group 4. And Cattrall's real contribution was he showed that patients who remained in groups 1 and 2 had a good prognosis whether they were treated or not, whereas patients who eventually ended up in groups 3 and 4 had a poor prognosis. So his work suggested that, oh, maybe some patients with Perthes disease don't actually need to be treated at all, because at the time everybody was being sent to institutions to be put on bed rest with their legs abducted. The other, I think, key piece of Cattrall's work were what Cattrall called his head at risk signs. And not all of them, but many of them refer to pathology and problems developing in this lateral margin of the epiphysis, what Herring later called the lateral column. And so if this lateral column shows signs of problems, so lateral epiphyseal calcification because it's soft and it's being squashed out, so lateral subluxation, Gage's sign, a kind of Pac-Man bite out of the lateral margin of the epiphysis and adjacent metaphysis, and then other things not quite so lateral like metaphyseal cysts and a horizontal growth plate. These three certainly show problems in the lateral column. Now, if the lateral column in Perthes disease is absolutely perfectly preserved, it really doesn't matter what goes on in the medial and the middle columns, because the lateral column holds the temple up, rather like Samson in the Bible story. But if Samson pulls the lateral column down, everybody inside has had their chips and they're going to get squashed. So that Cattrall recognized that, but he called it his head at risk signs. Salter and Thompson critiqued Cattrall's classification by saying, well, Cattrall's classification is no good for helping you to decide who needs to be treated or not, because a patient can only be given their final Cattrall grading at the end of the fragmentation process. And of course, on any given day when you look at a patient's x-ray, you don't know whether today is the end of the fragmentation stage or not. You only know a year later when it hasn't gone any further. So Salter and Thompson suggested that it was no good for helping you with treatment. So they described this subchondral fracture, which unfortunately you only see on about 20% of patients, but their thinking was that if this fracture extends less than halfway along the epiphysis, it suggests that this hip is going to be a Cattrall 1 or 2, and you might not need to treat this patient because they are likely to have a good prognosis if they remain in Cattrall 1 or 2. If, on the other hand, the patient has already reached more than halfway across with this subchondral fracture, this predicts the extent to which it's going to collapse. And so even before it's collapsed, you might be thinking to yourself, maybe I should do something about this now before it gets any worse. So they proposed that this was helpful in determining who you might decide to treat, even though perhaps it is only present in about 20% of patients. And then later, Herring devised this lateral column classification, which of course is column, which is actually the most useful when you're thinking about Perthes disease, I think. And Herring A is when the lateral column is completely preserved. B, it's affected, but it preserves more than 50% of its height, and C, when it's lost more than 50% of its height and it's become very collapsed. And again, the problem with the Herring classification is it does not tell you who needs to be treated, because patient only reaches their final Herring stage at the end of the fragmentation. So again, a patient who looks like this in the clinic today, if you see them in 6 months' time, may look like this. So just seeing that this is like this doesn't help you at all. Stillbirth's classification is also quite complicated if you look at it properly, but I boil things down into simplicity. And so Stillbirth's classification classifies categorically the end point. So after the Perthes disease has been and gone, and you're left with a reossified hip, it's classified based on spherical congruity, i.e. it's round and it's in a round acetabulum. And most of those patients have a very good prognosis. In the long run, they don't get arthritis. Aspherical congruity, that tends to affect older patients. So your acetabulum is established by the time you're 10 or 11. And if you then go ahead and get Perthes disease and your femoral head becomes aspherical, you have, so pardon me, I'm talking about the bottom one, aspherical incongruity. In other words, a round acetabulum and an aspherical head. It's a mismatch. It's a square peg in a round hole. It wears out quickly, and these patients get early onset arthritis, usually before they're 50, according to Stillbirth's patients, and in many of them, depending on how bad the mismatch is, long before that. And aspherical congruity tends to be what happens to younger patients. So they have an acetabulum. When their Perthes disease begins, their acetabulum has not completely ossified yet. And so even though their femoral head may become a funny shape and aspherical, they end up with an acetabulum that matches it. It's congruent. And so they end up with aspherical congruity, i.e. a middle ground prognosis. They do get arthritis eventually, but it doesn't normally affect them until they're in their middle adult life. So that's a useful classification at the end of your treatment of a patient, because you're going to tell them what the future holds for them. What about treatment? So treatment is very much based on where you are in that Elizabethtown classification. If you're Elizabethtown 1 and 2, and you're in the stage where your femoral head is still plastic, i.e. you change the external environment and it can be molded or prevented from deteriorating, that's what I refer to as early disease, and that is what I call really the treatment of Perthes disease. We'll touch very briefly at the end of the talk on late disease. And so late disease is really Elizabethtowns 3 and 4. When the femoral head is healing, it's no longer plastic. Changing the environment in which it lives will not change its shape. And so you have to, and so basically this is really the treatment of how you manage a deformed femoral head, be that because of Perthes disease or AVN from DDH treatment, or perhaps even AVN from SUFI treatment. So if we move to treatment and we look at what Perthes said, and the trainees that we teach say, well, if this is a process of degeneration and then regeneration, why do we need to treat it? And the reason that we need to treat it is the hip goes through a period where it's soft. And if you, in some patients, if you don't treat it, it will get squashed, and eventually it will reossify into this shape where it's more of a mismatch than it might have been had you have treated them. And the patient's prognosis with regard to how likely they are to end up here depends on how much of the epiphysis is involved, because of course, patients who remain Herring A never end up here, whereas patients who are in Herring C often end up here. The age at onset, so the younger you are, the more likely you are to end up with aspherical congruity. So the congruity is your escape route. You end up not so bad. So the younger you are, the more likely you are to have a better prognosis. And gender. So this is a condition that's much more common in boys, but when it happens to girls, it's often more severe. And certainly in our demographic population, they have a worse prognosis, even removing the fact that girls are physiologically potentially, a girl of any chronological age is physiologically older than a boy. So in theory, they're older. But even if you subtract that, girls do worse than boys. Whoops, keeps going back to that other slide. So knowing all of that, and when we see a patient with Perthes disease, what can we do about it? So can we stop the degeneration process in its tracks? And there are various groups around the world who are using at the moment using bisphosphonates to see if they can do that. But as far as we're aware, you can't stop the degeneration process. I don't think any of the studies have come out convincingly to show you can stop it. Can you speed up regeneration? So this is kind of the principle behind joint distraction. So there are, in older patients in the UK, there are groups of colleagues who are putting hip distractors on these patients, both to unload it. Now, if you unloaded the hip and you waited for Perthes disease to go through its process of degeneration and regeneration, you'd have to wear this device for up to 2 years. And nobody can wear a hip distraction device for 2 years. So there has to be some element of speeding up the regeneration process by unloading it and doing the magic of a distractor, as Elizarov described. And so there is a hint that that might be possible. But again, from my reading, I'm not convinced that any of these studies have shown that we can actually speed up regeneration, although at an anecdotal level, I have colleagues who say that they can. So you're left with, can we stop or influence femoral head deformation? And that is the mainstay of how we treat Perthes disease, because we think we can, and we call that containment. So in the past, in this country, containment meant taking your kids. So I think this is Oswestry, which was a country hospital that was set up to treat kids with TB and various other conditions. And kids with Perthes disease were sent away. They were put on enforced non-weight bearing with their legs abducted for months, perhaps years on end. And I think looking at the historical results of this, enforced non-weight bearing with your legs forcefully abducted is the most efficient containment treatment you can get. And the results of doing this, I think, were quite good at the time. But it's unkind and it's unaffordable now. And so various other methods of containment evolved, including things like the Petri cast, which might work, but again is cruel. Various types of braces. So this is the Atlanta Scottish Rite brace. And I think even in the hands of the Atlanta Scottish Rite Hospital, this brace doesn't work. And the patients that I've seen brought to me in this type of brace look like they've got both legs abducted, but in fact they haven't. They have their unaffected leg hyper abducted, and the affected leg is barely abducted at all. So it's a nice idea, but it doesn't work, and so we don't do it. And then there are various surgical means of enforcing containment, the most common being a varus osteotomy and alternatives like pelvic osteotomy, so Salter osteotomies, and in some people's hands, in the worst cases, perhaps even both, because you kind of get ultra containment by doing both procedures. So what's the question then about this? Does containment actually work, and what is the best method? So back in 1971, when Cattrall started his work, he got most of scientific studies at the time were anecdotal or case series, and so his response was the reported results of treatments are so variable that it's difficult to be sure that any series are strictly comparable. And from Cattrall writing that and then doing his work over the next 20 or 30 years, nothing much changed. And then when Herring started their landmark study in the 90s, he came to the same conclusion. It is difficult, if not impossible, to compare the results of these published studies. So back in 1994, we were left knowing that, well, people did containment treatment. It was a kind of accepted treatment. It was a good idea. Theoretically, it made sense, but did it actually work? Well, nobody really knew. So they did this, the LCP study, which is this landmark paper published by Herring and Co. And it was intended to be a randomized controlled trial. Problem is, it couldn't be a randomized controlled trial because none of the people who were submitting patients believed that sufficiently that randomization was the right thing to do, because they believed that their treatments actually worked. And so it ended up being 28 institutions, mostly across the United States, and I think one in Australia, submitted 337 patients to this. All of them were over chronological age 6, because there was the notion that children who are under age 6 do so well that none of them need any treatment, and so let's not include them. And so they subjected these patients not to randomization, but to the institution's favorite operation, which varied from some institutions doing nothing, some doing physiotherapy, some doing Salter osteotomies, and some doing varus osteotomies. And it boiled down to this: the patients who were offered operative treatment over any non-operative method, more of them, 60% of them, ended up with a better Stillbirth grade, Stillbirth 1 and 2 here. And fewer of them, fewer patients in the non-operative treatments ended up in these best Stillbirth groups. And conversely, fewer patients who had had operative treatment ended up in the Stillbirth poor groups, 4 and 5, and more of the non-operative patients ended up in the Stillbirth 4 and 5. So in other words, for some of these patients, containment treatment did work, and it is appropriate. The other things that the problem is, you don't know who the patients are. They suggested that this was mostly due to patients who the patients who ended up with a better outcome were those who were in the Herring B group. but also the BC border, because their numbers wouldn't fit, they invented another group, the BC border, so increasing another category and making inter and intra-observer error more prominent. But they also showed no significant benefit demonstrated for patients over age 8. I'm not sure that that's your experience in India, but that was what they said in the United States. So if you look carefully at all of this, drilling down into who did well and who didn't, if a patient remained Herring A from the beginning through to the end of their treatment, then they all did well, irrespective of age and irrespective of any kind of treatment. And that stands to reason, because if the lateral column remains intact, everybody inside is protected. Herring B, the patients who are relatively young, under 6, not chronological age, bone age, they had a uniform outcome irrespective of treatment. So if children who are under 6 can remain in Herring B, you probably don't need to treat them because they're going to do well. And the patients who benefited from surgical treatment were those patients who ended up Herring B and whose bone age was older than 6. And the patients in those groups who had surgical treatments, be it a femoral osteotomy or a Salter osteotomy, did better than the patients who had a brace or physiotherapy or no treatment at all. So these are the patients that you're looking for in the clinic, because these are the patients who you can offer successful interventional treatment to. If your patient eventually ends up Herring C, it doesn't matter how old or how young you are, you have a poor outcome. So, and that actually the results of that study were reproduced in the work that Ketchell had done 20 years before, and they're reproduced in another landmark paper here by the Norwegians in 2008, which again showed that patients who had surgical interventions did better than patients who had braces or physiotherapy. The other key thing to point out here is Benjamin Joseph's work, your countryman, because his point is, if you could treat these patients before they start to collapse, surely they would end up with a better results. And he showed that that was true in this paper. And so what you really want to do in your clinic is identify patients who you think are going to have a problem and treat them as early as you possibly can. Quickly looking at the under 6s. So we know that under 6s do well, don't we? Well, we don't. Most of them do well because most of them have got all of these factors on their side, but not all of them do well. And so here are 3 papers from around the world showing, oh, guess what? Children under 6 don't always do well. So maybe some of them might benefit from treatment as well. So if we summarize what we know about Perthes disease now, when the lateral pillar is completely preserved, Herring A, all patients do well. So these patients do not need treatment. If the Herring classification, if a patient becomes Herring C, they all do badly, irrespective of age. And if you did offer them treatment, it was a waste of time. But the problem is, in a clinic on any given day, when you see your patient, you don't know that they will remain Herring A, and you don't know that they will become Herring C. Furthermore, you don't know whether the treatment that you might offer might alter the pathogenesis, as Benjamin Joseph suggests, and a patient who would have ended up a Herring C, had you not treated them, had you left them, might become a Herring B if you treated them, and therefore might have a better outcome. And how do we approach the children who are under 6? Because yes, most of them do well, but not all of them do. So how do you decide who to treat when you're faced with a patient in the clinic who's got Perthes disease? So one of the things that we would certainly say is if they are Salter-Thompson B, in other words, you've got an X-ray that predicts that they're going to become a Cateral A, B, or a Herring C, get on and do something, because this is your best chance to do it. So that is one occasion where their X-rays help you to decide who to treat. Most of the time, X-rays cannot help you decide who to treat, and most of the time, the classification systems are used for retrospective outcome studies, which is how they were evolved and what they're used for, not for trying to treat people. So our philosophy in Liverpool is, irrespective of your age, if you've got Perthes disease on an X-ray or an MRI scan or a bone scan, every single patient with Perthes disease needs containment treatment. Now, that doesn't necessarily mean you need to offer them an operation, because some of those patients, particularly the under sixes, will have a good range of abduction in the clinic, and they are maintaining their own containment without you intervening. So we call that non-interventional containment. Patients who are clinically doing well, have a good range of abduction, have very limited symptoms, irrespective of what their x-ray looks like, do not need treatment. The reason I say irrespective of what their x-ray looks like is because children who get Perthes disease when they're under age 6 do often have horrendous looking x-rays, and yet their clinical picture is not nearly as bad, and they have a reasonably good range of abduction, and so you don't need to treat them. On the other hand, if you see a patient who has persistent loss of range of motion, in particular, persistent loss of abduction, and clinically they're doing badly. So this is what Cashwell used to call in the clinic a patient doing well or a patient doing badly. They're doing badly. Maybe they've got some horrible at-risk signs. They've got poor range of motion. They've got an increasingly troublesome limp. Then this patient has demonstrated to you that they are not maintaining containment themselves. And so you have to help, and you use your favorite containment procedure to help them. And so in our hands, for most of the time, that is a varus osteotomy. If you're going to do a varus osteotomy on a patient, you have to make sure that they meet the prerequisites of that operation. And so the prerequisites of that operation are that, because if you do, so I've already told you this patient's now earned his right to have a varus osteotomy, because in the clinic, when he's awake, he has very little abduction. But if you have absolutely no abduction because of mechanical reasons, for example, hinging, then doing a varus osteotomy is the worst thing in the world, because all it will do is it will make that patient have an adducted leg. And so what you have to make sure before you do a varus osteotomy, and this is why arthrograms are commonly conducted, you have to make sure that under anesthetic, that patient does have abduction. In other words, this lateral part of the epiphysis can be contained within the acetabulum. It may be that the femoral head's already a bit flattened, as you see here, but this has been contained. It's not being moved out. So this is a containable hip with a good range of abduction. And so this is a patient who would benefit from a varus osteotomy in our hands. So we tend to do this for children under 8. And here's an example of a patient who's done well. Everybody shows patients who've done well in their lectures, don't they? And in older patients, we tend to do a shelf acetabuloplasty. Why do we do that? So this is mostly indoctrination. So Tony Cattrall indoctrinated me into doing this. His hypothesis was that if you do a varus osteotomy in an older patient, that iatrogenic varus that you've created will persist, and the patient will end up with a short leg. And then you've got another problem to treat later. Whereas if you do it to a younger patient, after the Perthes is gone, it's got a chance of remodeling. And so this was his hypothesis. Plus, the other thing to show is that in older patients, certainly in American and European hands, these patients don't do as well with varus osteotomies. And so I've taken to doing a lot of shelf osteotomies for this group of patients, although again, in our hands, this is a relatively unusual age group. And so here's a patient who did remarkably well. They don't all do remarkably well. This group of patients in our hands do worse than the younger patients. And that really sums up how we approach Perthes disease or early disease or Elizabethtown 1 and 2 when the femoral head is plastic. Treatment of late Perthes disease is a different problem altogether. All it is really is the treatment of a deformed proximal femoral head. And as I say, that can be because of Perthes or DDH or any other childhood diseases. The principal problem that they get in late disease is hinge abduction, a short neck, a high trochanter, maybe a Trendelenburg lurch because their trochanters, their abductors have been defunctioned. And the go-to operation for this group of patients, because most of them have hinge abduction, is a valgus osteotomy or some kind of valgus osteotomy, like a Imhauser or various proximal femurs. And the principle of treating this is you do an arthrogram, which here shows hinging, which shows that the fulcrum's moved from the central femoral head to this point here, and the femoral head's being pulled from the acetabulum. Whereas if you put that hip into adduction, this is the position of best fit. So if only the leg pointed to the ground when the hip fitted the acetabulum best. And so it can if you do a valgus osteotomy. So this patient's included just to make the point that this isn't Perthes disease, this is AVN from DDH, but the principle of treating these patients is all the same. Other strategies that have emerged in recent years are so the surgical dislocation approach and so dislocate the femoral head, carefully preserving its blood supply, and lop off the bits that are impinging and do a relative neck lengthening by bringing the trochanter down. And so people report results of this. There are too few patients having been treated in groups like this to give you a clear answer. Anecdotally, these patients do end up somewhat better after the operation, but how long it lasts is another story. And then, so that's a new approach. And I think this is commonly practiced now. This is a novel approach, not so commonly practiced. So a hip dislocation, but a reconstruction to chop out the middle of the femoral head and try to make it as round as possible. And I don't, when you look at the results of this particular, study, from my point of view, I don't think that the results are especially good. 10 out of the 11 patients ended up having some kind of other operation sometime later. And so the court's out about whether doing clever things like that is the way forwards. So you know what it is, who gets it. We have no idea why it happens. You can classify it, although for the most part, classifying it is more of a academic exercise when you're doing studies. You understand I hope you understand our philosophy of treatment and how it sits with what's known in the literature. Where do we go from here? Well, where we go from here is my colleague Dan Perry initiated this BOSS study, the British Orthopaedic Surgery Surveillance Study, a good few years ago now. Now we have a lot of data about all of the kids in the country who have had SUFI and Perthes disease. And now we are about to embark, we hope, on another properly randomized controlled trial of surgical treatment versus non-surgical treatment for Perthes with patients. And hopefully we'll be getting all of our surgeons around the country to actually randomize their patients so that we can get an answer to this question for you. And Mr. Cattrall thinks it's a good idea, and so does Tony Herring. So we will see. Thank you. I'll stop sharing.
That's a great talk, Collin. That's a tour de force of Perthes, and we really appreciate your new insights, because being influenced largely by Professor Benjamin Joseph, I think most surgeons in India have a particular thought process about Perthes, and I think a lot of our assumptions are being challenged today by your very wise comments and observations. So I invite Dr. Harish and Dr. Vidyasagar to share a few cases so that we can bring some of these problems to light. Harish and Vidyasagar.
Dr. Collin, this is Harish. That was a wonderful talk. I had actually written down the set of few questions to ask you. I think most of my questions were answered with your talk. So
perfect.
So I just wanted to ask, what is the role of MRI in Perthes? Once you have an X-ray, it shows up Perthes. So do you still get an MRI? Does it help in your decision making?
So what is the role of MRI? So first of all, if you have a patient where you have they've got an irritable hip and there's no X-ray changes and you've excluded other things, then the MRI can be very helpful in identifying changes then. And in the past, we used to use a bone scan, but of course, that's a lot more radiation for kids. So now we use an MRI scan. Most of the time, as you say, you don't need that because you can already see it. By the time many patients present, there are already radiological changes. And what is the role of the MRI scan? In my hands, absolutely no role whatsoever. I think for determining treatment, absolutely no role whatsoever, because once again, an MRI, like an X-ray, whether however you classify an MRI, with a Cattrall, a Herring, or whatever classifications that there are, in 6 months' time, it might be different. And so it's only a snapshot in time. So in terms of there isn't, I don't think at the moment there is any investigation that can guide your treatment because they change with time. And all investigations, MRI included, and it might be very interesting because maybe retrospectively we'll be able to identify another group of patients who has a particular MRI pattern that do well, and that maybe in the future we will know who we don't need to treat. At the moment, that it doesn't do any of that. So it's really a research tool.
Okay, thank you. And what's your protocol for containment surgery without a surgical intervention? How do you treat those children?
Without
without a surgery. How do
without surgery? So absolutely nothing, because the clinic, it's a clinical evaluation. A patient comes along. This is more typically, let's say, a 4.5, 5-year-old. They will come to the clinic. They will have Perthes disease on their X-ray. It can look horrendous. It can look like it's a herring sea. And then when you come to examine them, they've got a full range of abduction. And provided they're doing okay themselves, I don't do anything other than keep evaluating them, because and I would see a patient like that when I first meet them, maybe in 3 months, and then after that at 6 monthly intervals, until I know that they are going to remain with a good range of motion. Your question would be, well, what if they come along, 6 months later and they're losing their range of motion? And once upon a time, when I was indoctrinated by all of the literature and Tony Cattrall, I would put patients like that into a serial abduction braces. And if you do that, you get their abduction back. And if you could send them to Osteri with that abduction brace on and make them non-weight bear for 2 years, that would be perfectly good treatment, because we know that the studies that did that, they did okay. The trouble is you can't do that this day and age in kids. So parents will not allow you to put their child in a Petri cast for more than a few weeks. So when I did that, I would put them into a serial cast, and I would change it every week, getting more and more abduction. And at the end of maybe 6 weeks, I've got a very good range of abduction. And I think, good, I've restored their abduction. I'm going to let them go, and I'm going to let them be okay now. And my experience of doing that is that the vast majority of the patients that I did that to, they ended up losing their range of motion eventually again, some weeks later. And because I was determined not to treat them, because they were in this group that should do well, the under 6s, I didn't treat them. And now when I come, well, I've just retired and returned, but as I come to the end of my career and I pass on some of these patients to my colleagues, I look at them and I think, that was a patient who was young, they should have done well, but they didn't. And that was because I didn't treat them. And maybe had I have treated them, they would have done better.
I think, I just wonder whether you use the brace. So you said you don't use any brace. So
don't use any braces.
Quite difficult to use the brace. I come across a lot of patients from a rural background, so hardly have.
I think in your circumstances, a brace is something is better than and that, I'm not even sure of that. So you would think that something is better than nothing, but it might not be.
I don't know what has worked for us is insisting on putting the child on rest and putting them traction just for a kg or something, about a kg. A kilogram of weight, so that will confine the child to bed and give some rest to the joint, and it's a kind of non-weight bearing. So
and I think that treatment, if it can be maintained, it does work, because I know that there's I forget where it's from. I read a recent paper showing that they had some success doing that, and I also know that the historic papers where children were strapped to the bed and kept there for 2 years, I know that worked, but in our culture, the parents will not, that just isn't allowed anymore. And we all practice in different cultures. So what you do depends on what the families will let you do, doesn't it?
I have a couple of cases. Maybe Dr. Sagar, do you want to ask any questions?
Yeah, Dr. Collin, I had a question.
Yeah.
What do you think? Is there a role for this primary pelvic osteotomy for containment, or you always do the femoral? So
my indoctrination has been varus osteotomies, as perhaps most of yours has been through Benjamin Joseph, and mine was through Cattrall. If you worked in Toronto, you would have been indoctrinated into doing a Salter osteotomy, because that was their go-to procedure. And the hypothesis, so the thinking behind which one is better. So, because of course, perhaps doing both is even better, because doing both have complementary effects. So a varus osteotomy, so the argument from the Salter group would be a varus osteotomy leaves a patient who already has a short leg and who's going to have a shorter leg because of Perthes disease. A varus osteotomy gives them an even shorter leg. Yeah. So there would be a good reason, therefore, for why don't you do a Salter? Because it will give them a longer leg. And the varus camp would argue that if you do a Salter to get containment, but then make their leg longer, relatively speaking, they get less containment because they have a long leg dysplasia. And so the lengthening of the leg is counterproductive to the containment. And so there is some sense, although most of us don't do it because it's even more invasive, to actually do both.
And does this pelvic osteotomy, I think theoretically there is a chance that it may increase the pressure on the vascular.
Yeah, indeed. So if I was going to do that, I'd cut the psoas like you do in DDH, because you generate pressure otherwise. But of course the Herring study shows that actually when the Herring study was first reported at the American Academy that I was present at, they were coming out in favor of varus osteotomies, but when they did the final analysis at the end of it all, there was no real difference between a Salter versus a Perthes disease. So it really depends on which religious text you read.
Thank you.
Yeah, I think just a couple of cases. So, Dr. Pali, can you see the X-ray?
I can see them, yeah.
This is an X-ray of a 5-year-old girl who presented with quite good range of movements. Only symptom was a painless limb. So she was in the early stage of Perthes, that's in vascular necrosis, and it appeared contained. So she was being managed conservatively with a regular follow-up.
But just to pick you up on that, it appeared contained. Containment is not a radiological phenomenon. It is a dynamic lifestyle phenomenon. So it depends on their ability to constantly abduct their hip throughout the day, every day, all day. It's not a static thing.
Yeah, I got it.
So you could say it looks containable, but whether she's containing it or not is another story.
Okay. The ossific, what I meant is the ossific nucleus appears, most of it appears to be under the acetabular rope.
So I'll tell you my thinking as we go through the slide. So in a 5-year-old girl with an X-ray that looks like that, who's got very limited symptoms, that kind of fits Catterall's definition of a patient doing well, and you might reasonably sit and watch them. What I would say is that to be doing well, you must be able to abduct that hip comfortably. Trainees often say to me, "Oh, how much abduction should they have?" And my answer is almost all of it. So it's not so patients who've got an irritable hip because of synovitis, because of Perthes disease, they either do or they don't have abduction, and it's pretty obvious. And if they don't, and if they have a hint of irritability that's stopping them abducting, so let's say they only abduct to say 15 degrees, that's not enough to contain that lateral column. And so now, so I didn't practice like this in the past, but now if I have a 5-year-old girl come to the clinic with an X-ray that looks like that, and she can only abduct to 15 degrees, I'm going to list her for a varus osteotomy today, based on the fact that she's not containing it herself. And your countryman, Benjamin Joseph, says the earlier I operate, the better the outcome.
Dr. Collin, one question, because you're mentioning about the containment assessment. Now, is it purely a clinical assessment before the surgery or assessment in the operating table with the ortho?
Yeah. So right now in the outpatient clinic, the assessment of abduction is purely clinical. And of course, you have to make sure that these kids don't cheat, because if you abduct both hips at once, they give the impression they can abduct a long way because they're hyper abducting their normal hip. So you have to lock their normal hip on the table, make sure their pelvis doesn't move, and then test their abduction. And only then have they got, if they have a good range of motion, I would decide to treat them non-surgically, non-interventionally anyway, because they are containing their own hip. If, on the other hand, that patient has got restricted abduction on that day, now, in my care, that patient has just received a certificate to have a varus osteotomy. Now, she has to meet the prerequisites of the osteotomy, which means that under general anesthetic, she must mechanically be able to abduct, and that hip must be containable in order for me to do the operation. After you've done a varus osteotomy, I always put the patient in a spica, and Jay, I think, knows this to his cost, because if you don't put them into a spica or an abduction splint of some sort immediately after the operation, their immediate response is to adduct, because the hip is still painful in abduction. And you have to hold it there for a few weeks until it stops being painful in abduction. And then they can, so if you don't use a spica, because of course the fixation we use is strong. So the spica is not really there to protect the fixation. It's there to force them into an uncomfortable position for a few weeks until they stay there. And then once that's recovered, they do seem to, they never get stiff again. In fact, quite often, even though you have absolutely removed some abduction range by doing a varus osteotomy, those patients can often abduct much further in the clinic 3 months after a varus osteotomy than you would expect. I don't know whether anybody else has that experience.
Yeah, we have seen that, and I really am thankful to you for highlighting the point that prerequisites, having a good range of movements before we do a varus osteotomy, because I've seen patients doing worse when they're operated on a stiff hips.
Yeah.
I mean, we have not followed the protocol of putting a spica. Maybe I think we let. How long you put this spica after the varus osteotomy? For 4 weeks.
4 to 6 weeks, just until, and again, it's the reason I do it is for the reasons I've explained. These are the reasons that Catterall explained to me, and so I've been indoctrinated. But the only evidence that I have that it is true is that Jay once decided not to put a patient in a spica, and the patient got stuck in adduction. Is that right, Jay?
So coming
and thankfully, he ended up being your patient. So
yeah.
Coming back to this child, so she was being managed conservatively and followed up on a regular monthly basis. So the next 7-8 months period, she lost a range of movement and the head started to extrude. She was being managed conservatively because, as I said, clinically she had a good range of movement except for the limb.
Yeah.
So subsequently, she started to extrude laterally. That's when we changed our gaze, and we consider containment by a varus derotation osteotomy. I think she was still in a fragmentation state, still in early stage to do a containment. It's a plastic head.
And that's exactly what I would have done too. That would be my. I would have probably managed that patient in exactly the same way that you did.
So, like a prerequisite, what you said here, after synovitis subsided and a range of movements improved clinically, only then we took her up for surgery, because to start with, she had a stiff hip because of synovitis. And she went on to do the latest X-rays when she was 9 years old. I think probably she'll end up in Stillbirth too when she matures skeletally.
And again, of course, the Stillbirth grading is based, it's kind of boiled down to three categories in my world. So this is aspherical and congruent, but actually the aspherical and congruent group is a very disparate group, because some of them are more spherical than others. So that's almost the Stillbirth 1, 2, isn't it?
So clinically, she was quite normal in the sense she didn't have any limb, and range of movements are comparable to the normal limb.
Yeah, so she's good. Nice result.
So another child who was a slightly older boy, 8 years. He presented with a stiff hip, which basically clinically it appeared to be synovitis, which improved with the period of traction, rest, and NSAIDs. So he was again in stage 1A. So when we follow the protocol, what was laid down by Benjamin Joseph, so he's already more than 6. And so we straight away went ahead and did a containment surgery for this boy. So at presentation. So subsequently, you can see that this is actually 1 year after the surgery when we did the implant exit. And we can see that how the head has collapsed. So had this boy not received a containment surgery at an early stage, so his head would have actually gone for quite quite more than what he has. So I think this highlights probably the importance of an early
treatment. The other thing that I would say is, because often patients look at their x-rays like this and they're horrified because to them, it looks like their Perthes got worse after you treated them. So one of the things that I always tell them is that we're going to do this operation. This operation does not cure Perthes disease. This makes the best of Perthes disease, and the disease will continue to progress after we've done the operation. Otherwise, they kind of think you're to blame for this.
So like you highlighted, the herrings, it progresses with as the stage of disease progresses. So this I actually ended up in having herring C.
Yeah.
So if not for containment, I think it would have been much worse.
I agree.
So, it's at 2 years, and this is at 5 years after this surgery. And, I mean, the prerequisite for most of our patients is being able to squat and sit on the floor, like what he's doing.
Yeah, yes, that's amazing. He can do that. That's brilliant.
He didn't have any lurch, no limb discrepancy.
Mm.
And this is at 5 years after the surgery. He's now 13 years old. I feel he probably will end up in a stillbirth too when he's nearly skeletally mature.
Yeah, looks good. Fortunately, our patients don't have to squat like that, because that's a real requirement in your culture, isn't it?
Yes. It's very important for them to squat either at work or to use the toilet. So it's one of the very essential things in our patients.
Yeah, of course. Yeah.
So these are the two cases.
Harish, I have one comment and one question to Collin. The comment is, if people start squatting at a younger age, I believe that they remodel their head better. They hyper-contain often, and the plastic head probably remodeled. That's why I believe that in my generation in India, we squatted a lot. FAI is much less common. I mean, than the people your generation who don't squat as much. And I see more and more FAI in India, idiopathic FAI.
In India than in the United States?
In India. So I grew up in India, so I squatted a lot in India.
Yes. And they have they do or they don't have FAI?
They have less FAI.
They have less because they've been molding their head their whole lives. Yeah.
Right.
Yeah.
So if you believe in that monkey hip thing, if you mold your hip early on, you'll have a round head.
Yeah.
You're less likely to have a cam deformity.
Yeah.
My one question to you, I mean, this is not a standard, it's anecdotal, but even if late stage, like Elizabethtown later, like 3. Yeah. What's the harm in containing? I know the head's not going to be spherical.
No, there isn't. So yeah, that's a good question. So I think so. I contain them anyway, because what is the harm? Well, it depends on you. So harm, what's the harm of doing an operation that might not work? Well, the cost of it, both financially and the cost to the family. But on balance, when patients present with a hip just like this, my go-to operation for the older patients is a shelf. But I now wonder whether, doing hyper containment with a shelf and a pelvic osteotomy would be the right thing to do for somewhat older patients who've got a worse prognosis. So yeah, we do contain the older patients. We don't just abandon them.
The reason I think containment is a good idea, as long as the phi radiate is open, is that if you leave them subluxated, the style will become more dysplastic. Yeah. And if you don't do the shelf or containment, the lateral head that extruded will be bilobe, requiring a bigger reconstruction later on.
Yeah, I believe the same.
That's great. If we don't have any more questions, I think I'd like to invite Dr. Prasad to talk to us about his thoughts on slip capitofemoral epiphysis.
Thank you, Jan. So as you know, my topic is slip capitofemoral epiphysis. I'm right now in India at Amara Hospital. But this is where I practice on alternate months in Chicago, Christ Medical Center. I have no disclosures except that I'm very passionate about this topic. The main reason is, like a DDH and Perthes, in contrast to DDH and Perthes, most KP is operative, and operative for a good reason, with reasonably good outcomes. So introduction, it's a common hip disorder. The head slips on the neck almost always posteriorly, and usually inferiorly, a varus slip. Valgus slip is well known, not as common, 2 to 4%, but anterior slip is, I think, is reported. I've never seen one. This is a typical posterior slip with some varus. The head slips posteriorly with some callus in the back. It's a chronic stable slip. Again, look at the head slipping with callus formation. This illustrates that a screw or a wire placed to the lateral cortex of the femur to the center of the neck will exit quite anteriorly. Right? It won't be in a good position to resist the slip from progression. A few textbook things. It's typically between 10 to 15 years. If there is less than 10 or more than 15, you call them atypical and look for endocrine pathology. All these things are more demographical, but left hip is more common for a few theoretical reasons. I found that they're associated with Perthes. I never saw Perthes with slip. Never saw perineal flat foot, but I've seen some Blount's kids with the slips. Several endocrine pathology can be present, pathology. Hypothyroidism is the most common. Growth hormone deficiency, it's not the deficiency that causes slip, but it's the treatment with growth hormone that causes a slip. We've got contralateral slip. About 20% present with bilateral slip. And about 20% develop later on the contralateral side. So it's important to follow them. If you don't prophylactically fix them, even if you fix them, you need to follow them. There's one study that says that weight loss actually decreases the risk of slipping on the opposite side. If somebody is obese and you're good at convincing them to lose some weight, that may help. The risk factors for contralateral slip are again less than 10 or more than 15. Open triridia, that's what I use routinely, easy to look at. And all these scores are a little harder for me. And then any atypical slip, it's a good idea because the risk is very high in any of the endocrine pathology or any renal disease or other known causes. The pain can be anywhere, hip, thigh, knee. In one paper, about 50% of slips present with knee pain. It's important to examine the hip and get a hip X-ray. They often limp, either from pain, antalgic, a little bit Trundle-Berg from pain or abductor dysfunction. But most commonly, they walk with outgoing. The majority of the kids are obese. And there can be some limb shortening based on the severity of the slip. So gait deviations are noted in multiple studies. Like I said, most commonly it's outgoing gait. But most important sign for me clinically is an obligatory external deformity. It's that Breman sign. You flex the hip up to 90 degrees. Some people call it axis deviation. Look at the leg, which way it rotates, the tibia. And if you don't have enough internal rotation, that's an impinging hip, or you have either slip or some other cause of impingement. If they have obligatory external deformity, they can't sit, they can't squat properly. When they can't sit properly, they can't squat properly. Riding a bicycle become very difficult. And older scales that did not look at all these things showed good function. Like the Iowa study, they said all these kids do well, but they didn't really look at their function for sports and flexion activities, I think. So the pathoanatomy, widened physis, weak perichondrial ring, decreased mammillary processes, small tubercle, retroverted femur, acetabulum, posterior and varus slope of the physis. All these are associated. Are they the cause or are they the part of the slip? Is it the pathological process? This have examined bilateral hips of flexion 90 degrees. The right hip internally rotates to about 15-20 degrees, about normal. The left one is externally rotated by 5-10 degrees, right? This is obligatory external rotation deformity to a mild degree. So this patient has a Breman sign positive about -10 of internal rotation, which is suggestive impingement, if not a frank slip. A more severe slip, this child cannot even sit properly. He has to support himself with his arms to get up to at least 60 degrees of trunk to femur flexion. It's not even hip flexion. His whole back is being used. And he has to support himself. And look at how he crosses his legs. He can't keep his legs apart and still sit up. And this is how much obligatory external rotation deformity he has with the hip flex to 90, not even 90. I probably got to about 60 or 70. And he went out to about 70 degrees. That's a severe deformity. You don't expect these kids to do very well. You put them inside to clinic. Radiographically, lateral view is the money view, but you have signs on the AP view which show hints of a slip, but the lateral is, I believe, is a must for also when you suspect a slip. Negative X-rays may have a pre-slip. CT scan shows the severity and facial closure. I rarely use it, but you can use it to look at this deformity because it's an oblique plane deformity. Either AP or lateral will show the full deformity unless it's a perfectly done view for that particular slip. So CT is very good to measure the actual deformity. MRI can show edema in pre-slips to diagnose pre-slip. Sometimes you use it to see if the physis is still open or not. Lucency of the physis on an X-ray is not certainty of an open physis. I have a few cases where I went in thinking the physis was open, wanted to do a done osteotomy, but found the physis to be ossified in spite of looking lucent on the X-ray. The MRI can show you preoperatively facial cartilage. I rarely use ultrasound, but it shows an effusion if there's irritation and can show next step of the same. So what is in the AP view? You see varus valgus very well in the AP view. Some growth rate widening and irregularity can be seen. Klein's line is a sign I'm going to show on an X-ray. And Seal's Blanche sign is an overlap of the head on the neck. It's a subtle slip. You may say it looks normal, but this growth rate looks a little wider than this one. And if you draw a little bit of a Klein's line, that's epiphysis that's lateral to the Klein's line on this AP view. And there's a little bit less of the epiphysis lateral to the line, suggesting a subtle slip in this patient. But the lateral view will show you a posterior slip. Here's an example of valgus slip. This patient on the normal side has coxa valga, severe coxa valga, with head subluxating. And on the right, similar pathology, but with an additional slip. So here, the Klein's line will not be helpful because the epiphysis will be, much more epiphysis will be lateral to the Klein's line. The lateral view is the money view where you can see the slip angle, the posterior slope of the slip. You can see the translational deformity in addition to the slip angle. You can see the prominence of the neck anteriorly. You can start measuring alpha angle to see if that's amenable to osteoplasty. You see the callus in the posterior aspect. And remember that no lateral view will show the maximum amount of slip, in all the slips. So a CT scan will show you the deformity better because of the oblique plane deformity. A mild slip. The true neck, right? Probably somewhere like this. The anterior neck is already resorbing from the constant impingement. So the sharpness of the anterior neck is rounded off already, the so-called remodeling. This is the callus on the posterior aspect. Right? The slip looks much worse now as I do this neck outline. It's not as mild as you thought. One slide to show you, an idiopathic cam, the bump is epiphyseal cartilage. In a slip, it's metaphyseal bone, the neck bone that impinges and gets worn out. It's not an epiphyseal deformity. So idiopathic cam is different than a slip. Coming to classification. Acute, and chronic are more like temporal classification, has not been as useful. But stable and unstable is a little more useful to predict the risk of AVN. A stable slip has almost negligible or 0% AVN rate. An unstable slip can have an AVN rate anywhere from 10 to 47%, even with inside to pinning. Southwick classification is the most commonly used classification to grade the slip on a lateral view usually. Based on the slip angle, you have 3 grades, mild, moderate, and severe. Then there's one classification that people don't use at all based on the percentage of translation of the slip. Because the translation cannot be seen very well with the remodeling. But translation is a very important aspect of the slip, where with a small slip angle, you can have a lot of obligatory external rotation deformity. Here's how to measure the Southwick angle on the right hip. There's a shaft neck axis, facial line, and the perpendicular to that. The angle between the perpendicular and the shaft neck axis is your posterior slope. Southwick said about 12 degrees is normal posterior slope. And if you deduct what you get on the opposite side, the 12 degrees off the opposite side, that's a true measurement of slip angle according to Southwick. And 0 to 30 is mild, 30 to 50 is moderate, and more than 50 is severe. So few things about radiographic deformity. There are several studies, including Mike Miller's study, that said X-rays underestimate the deformity. Like I said, CT scan is better. The deformity remodels without changing the slip angle. So what you see on X-ray may be a remodeled, lesser picture of the slip. And what degree of slip deformity does not correlate very well with clinical deformity. A 15-degree slip in one person may cause navigator external deformity about 20 or 30 degrees, while on the other person, it may cause only 0 degrees of deformity. Because things like femoral version, established depth and retroversion were not taken into account when you measure only the slip angle. Historical treatment, spica cast, I never saw it being done, even in my training in India. I saw a case of bone peg with featuredesis being done. Multiple pins are out of favor because of the risk of penetration, but they work well if you put the pins adequately in the head. Multiple osteotomies are described from the 1960s onwards. Fish, Dunn, Kramer, it's more like a base of the neck osteotomy. Sugioka osteotomy at the base of the neck, Hauser, intertrochanteric, Southwick, subtrochanteric. All these have been done a few decades ago. But single screw has become the favorite based on this study from Iowa that said that all osteotomies have much higher risks than putting a single screw, right? But this was based on, I think, not flawed, but not really good functional evaluation of the patient's sports and activity function. Examples of few osteotomies. Fish osteotomy was done at the level of the physis, subcapital. The base of the neck osteotomy is the Southwick intertrochanteric osteotomy. All these work well if you relieve the impingement and give them good range of motion without causing AVN, of course. So now I spent the next part of my talk on femoral established impingement in slips. RAB brought out computer modeling and showed that most slips impinge. Loening showed clinically that there's a lot of damage with impingement. Sink also showed with open surgical dislocation approach, a lot of damage in slips. And Millis, I'm going to show a picture of it from his article. So most slips have labral and established cartilage damage, pretty much almost always, right? Restricted range of motion with some pain is common if you examine them carefully. There will be some difficulty with flexion activities in most kids with slips. And if they are active in sports, they can have pain with walking and running also. This is a picture from Rob's article where the slip, the displaced metaphysis can impinge against the established rim and dig into the established rim and wear out. And after remodeling, this can actually rub on the articular cartilage more and more. This is a picture from Mike Millis's paper that showed a mild slip causing a lot of labral insert type of damage and abrasion of the articular cartilage. So the current opinion, based on my understanding of the literature, is Dremann sign is equal to impingement. If you have obligated external rotation deformity, you don't have enough internal rotation of 15-20 degrees, that's a sign that the hip is impinging. Established damage is seen even in mild slips. Several papers showed that, including the one we published. People thought that slips did not lead to total hip replacement, but a Mayo Clinic study showed that at 16 years of follow-up, even in mild slips, right, they were getting total hips. And one paper from NERD said 45% of slips got total hips at 50 years of age. It's as bad as Perthes. Gans recommended that osteoplasty should be done for slips under 30 degrees of slip angle and that osteotomy for worse slips more than 30-degree angle. But like I said, 30 degrees is not equal in every, it does not correlate with clinical deformity in every hip. So my personal experience is FII is very common, but not always present. FIR, the flexion internal rotation, which is another way to look at the rotation, rotational deformity, the good measure of FAI. Radiographic deformity does not correlate with obligated external rotation deformity, right? So I use clinical deformity more often than X-ray deformity measurement. Remodeling at the expense of remodeling happens almost always at the expense of established cartilage damage. You may not see it on X-ray, but it's always present when the hip is remodeling. That's the only way the metaphyseal bone grinds and wears off and remodels. Even mild slips develop arthritis. I'm going to show you some examples. I do quite a bit of arthroscopy for slips. So this is a mild slip, right? The metaphyseal bone. It's mild enough to enter the acetabulum without jamming onto the labrum and the acetabulum rim. And you can see the abrasion of the articular cartilage from this bony spicule. Intense synovial reaction from the damage to the sternum. A lot of synovitis. The 15-year-old, moderate slip, inside to screw was fixed by somebody else, came to me with arthritis at 15 years of age. Another 15-year-old, severe slip, joint space narrowing. 19-year-old, look at the osteophytes around the hip. That's the arthroscopic picture. The acetabular bone is a subchondral bone is exposed because the cartilage is also worn out from a counter-coup mechanism posteriorly from an anterior slip. The 26-year-old cast technician, one of the hospitals I worked at, complete loss of cartilage. And this one is a mild slip, right? You all agree that it's a mild slip. Again, this is how, when the neck doesn't remodel, it's going to crush the labrum. And when it remodels, it enters and abrades the articular cartilage. Again, last example of advanced arthritis, even after a base of the neck osteotomy for a slip. So this is my bias now. Treatment options. I have 4 treatment options. I can do inside screw fixation, works very well to prevent progression, but it only freezes the deformity, does not correct the deformity in any way. I don't believe that remodeling actually corrects the slip deformity. It only decreases the neck prominence. Reduction of the slip and screw fixation is an option for unstable slips, and it becomes safer if you monitor the blood supply. So somebody doesn't have too much callus in the back of the neck and has an unstable slip, it's probably reasonable to do a closed or open reduction and somehow monitor the blood flow. You can do it even with closed reduction. You can put a probe through the head into a drill hole. And if you monitor the blood supply and fix it, it's probably a reasonable option. Anybody with some callus, right? Osteoplasty is an option if it corrects the impingement completely. If osteoplasty alone is adequate, right? The impingement is mild. You can put a screw and do an osteoplasty. Doesn't matter if it's arthroscopic or open. And then anything more, they're impinging. A corrective osteotomy is probably a better idea if you can do it safely without causing AVM or chondrolysis. So in my mind, my mild slip is, it can still be under 30 degrees. The degree is not as important. They do not have any obligatory external rotation deformity. They have good section internal rotation, 10 to 20 degrees, right? No limitation. Toes are pointing nicely forward, no outgoing gait, no abnormalities. And on the X-ray, you see the joint contact to be adequate. The epiphysis and the acetabular cartilage have good contact, not too much deformity. You don't see the neck pointing into the acetabular. Then inside to pinning alone should be adequate. No impingement, no significant deformity. Pinning inside too is good. Example. The brightness a little bit. I don't know if you can see it. A 10-year-old girl with hypothyroidism got screws on both sides. Though I see the slip angle to be probably about 20-25 degrees, and I see metaphyseal prominence, you're not impinging at all. There's good range of motion, no pain. I left her alone. That probably, the articular cartilage probably extends to the same level of the neck, and the neck probably does not going to abrade the articular cartilage. So ideal inside screw fixation, a larger screw, more like 7.3. Fully threaded cannulated screw is a good idea because fully threaded screws are easier to remove, and you don't need to measure how many threads you have on the neck side, because ideally you should have 3 to 4 threads on either side of the physis. So fully threaded screw is ideal. You have good purchase on the neck and adequate number of threads in the head, 3 to 4 threads in the head. Regardless of where you start the screw tip should end at the center of the head. The tip should end at the center of the head. The advantage of that is you're not going to be fooled by the X-ray view. You cannot miss articular penetration. The tip is in the center position. If it's not in the center, it can be out and you may miss it unless you do a very thorough evaluation, like around the world fluoroscopic view or something like that. We published a couple of papers on this oblique screw. People used to say you need to put a screw perpendicular to the physis. That usually ends up being in the anterior neck. that can cause screw impingement. But the way I do the oblique screw, right? You put an oblique screw like this, get a good cortical purchase laterally. The screw is buttressed by the posterior part of the neck, and then you're still in the center of the head, and I get an extra thread. So we published the advantage of this fixation in a couple of studies in JPO. If you put a perpendicular screw, look at how this head is very close to the rim. You cannot do adequate osteoplasty. The screw head will come in the way. The screw head itself can impinge against the labrum and the articular cartilage. A moderate slip, say roughly a slip angle between 30 and 50, like Southwick said, but more importantly, I have impingement, a deformity of around, say, 15-20 degrees of external rotation deformity, some outflowing gait, some limitations in function. They're all vague and non-specific, but what's important is, you look at your X-ray, measure your alpha angle and say, can I change the alpha angle to give me the internal rotation I need to get rid of this obligatory external rotation deformity? Say I have 20 degrees of rotation deformity, I want to get plus 10, and if my osteoplasty can give me 30 degrees by the change in alpha angle, I think that's a good case for an osteoplasty. But the caveat is you should have good joint contact. You shouldn't have the neck projecting into the acetabulum on an AP view. Then a femoral osteoplasty is a good idea. And we had one paper published in Arthroscopy Journal. This is a typical oblique screw placed in the head, an osteoplasty. So you don't wait for natural remodeling, which occurs at the expense of the acetabular cartilage damage. To take out the bone prophylactically, so it won't damage anything. And in our paper, we did not have any additional complications because of this osteoplasty. It took extra time. It's more expensive, obviously, but it did not cause any additional complications. Here's a typical example. Somebody with the slip that's almost 46 degrees. This is when I did not recognize the contact area problem of the head and the acetabulum. So all I measured was the alpha angle. This alpha angle is probably close to about 100, 105 degrees. And I know that I can change it by about 45 degrees. So my minus 20 will become plus 25 if I took this bump off. And you can see my post-operatively, I created the roundness of the head, right? This is the damage she has inside. That metaphyseal bump was abrading and rubbing on the articular cartilage. And this is the girl soon after surgery, about plus 25 degrees of rotation, about 5 years later, very symmetrical and doing well. Severe slip. There's no big controversy about this. The deformity is pretty significant. They have severe deformity clinically that you know that your osteoplasty is not going to be adequate, and they have limitations of function. Okay. These, I believe, should get realignment osteotomies early before they become symptomatic. For me, symptoms mean that a lot of damage in the hip. I know that I'm biased because I saw a lot of damage in the hips, even in milder slips. So I tend to correct them when they have severe clinical deformity without waiting to see how they do after inserted screw fixation. I do more subcapital osteotomies, but that's not has to be the way. You can do an osteotomy at any level as long as you take care of the impingement and do it safely. This is a typical modified done osteotomy. We go to the fascial surgical dislocation approach, go to the physis, clean the callus, reduce the head back onto the neck, pretty much anatomic. So here's an example of a 12-year-old male who came with bilateral moderate to severe slips, clinically severe. About a 40-degree deformity on the right and a 30-degree deformity on the left, clinically. And the slip angles are pretty probably in the severe grade on the right and probably moderate grade on the left. And this is not amenable to osteoplasty. If I want to do an osteoplasty to improve the range of motion, the neck will become very thin, and also there will be very little contact between the epiphysis and the metaphysis. I mean, epiphysis and the acetabular cartilage. So this is a 5-year follow-up. Bilateral modified done osteotomy is done sequentially. I think the interval between the two was about 6 weeks. And this child did well, in spite of the horrendous looking callus and all around the trochanteric osteotomy. Most of these kids do not impinge. This is extra-articular and they usually have good function, good range of motion. Again, it's lateral view. Again, there's mature, but not impinging. So you can monitor the blood flow intraoperatively to make sure that you did not damage it during the case. A drill hole in the head with brisk bleeding is pretty reliable in my hand. A small little ooze of blood may not be as reliable, but if you have active red blood coming out, that's arterial. So that cannot be a false bleeding from anything else. This is an example of somebody with open-looking physis. So I pinned him on one side, did the done on the opposite side, then went back around 6 weeks, and this side was solidly fused. I don't think it healed within 6 weeks. I think this was fused, and it looked like it's not. Another example, this one I would not believe that it's open anymore, but at that time I thought it was open, the physis. So I ended up trying to do went in to do a done osteotomy, but ended up doing a neck osteotomy because done is not as safe when the physis is fused. You do a neck osteotomy, then take out this metaphyseal bone, and you can see how after you cut the neck, the head still bleeds quite well if you preserve the retinaculum going to the head. Then we remove the metaphyseal bone from the neck, make it concave. Again, the head bleeds continuously, giving you confidence that you're not doing any damage. So treatment summary for me, SCEPI is becoming more and more common in India. I'm seeing less and less of SCEPI in the United States right now, and I'm seeing more and more SCEPI in India. FIR, flexion internal rotation, or the Dreman sign, adds to the deformity analysis, to the radiographic analysis. The moderate group is not very well defined. You know it's easy when they're not impinging, and it's easy when they're severe. The moderate group needs some refinement. It's more subjective right now. The only thing I have is alpha angle measurement. And keep in mind that osteoplasty and osteotomies are not easy, but they can be learned. Osteotomies, the done osteotomies, have AVN rates reported anywhere from 0% from the Swiss to 66% from Toronto. That's very variable. It's all surgeon dependent, it's technical. It's not as much a bad operation, it's just that you need to learn it correctly. A few things on complications, just a couple of slides. Avascular necrosis is a dreaded complication. You sort of know why it happens. Either you damage it intraoperatively or something happens postoperatively where it obstructs the flap of the blood flow through the retinacular vessel. Chondrolysis, I have no idea what caused chondrolysis, except when the screw is penetrating into the head, I understand, but otherwise, we don't know what caused chondrolysis, but luckily most resolve. Slip progression is a problem, but a good screw fixation, like I showed you, nice big screw in the center with good threads on either side, minimizes slip progression. Non-union is a problem if you put bridging threads on either side of a osteotomy. You want threads on either side in a stable slip, but you don't want threads on both sides of the physis in an osteotomy, like a done or a neck osteotomy. You want to lag it and allow compression afterwards. And HO is very common, but usually not symptomatic. So like I said, chondrolysis, it's my observation that if you observe without doing much for chondrolysis, most of them improve. And a couple of papers support that. It takes about 1 to 3 years to improve. Avascular necrosis is not common even in unstable slips. Only 10% if you do take care of the unstable slip in a acceptable way, in my opinion. You monitor the blood flow, whatever you do, done osteotomy or just an open reduction or a closed reduction, but monitor the blood supply and adjust your reduction to have good bleeding in the head, then 10% is probably traumatic. So anything more than 10% in unstable slips is probably iatrogenic. And of course, stable in neck osteotomies, AVN is almost always iatrogenic. The collapse can happen within 6 to 12 months. One case example at the end. But this is the only case that I know of that documented traumatic retinacular damage. These 3 holes are where the vessels go into the head. But when I did the done osteotomy, the retinaculum was already peeled off. Right? You can't save this head. So today I will inject bisphosphonates into the head prophylactically, not prophylactically, therapeutically, to see if I can save the head. This is a done osteotomy which I did. The head did not bleed at all in this child. No bleeding intraoperatively, unstable slip. Right? Bone scan was cold, postoperative day 2. So definite AVN, I thought. Put him on PO bisphosphonates early in my career. He did not take any bisphosphonates, kept running on this hip, came back about 6 to 7 weeks later with this. So I went back in, the head was bleeding very well. So what I'm going to tell you is, not all ischemic heads in the early period after unstable slips will go on to collapse. That may be just transient ischemia that can resolve with proper alignment of the head. Thank you very much.
That's great. Thank you so much, Prasad, for a really exhaustive talk on SEFE. I think you've really changed the mindset of the average orthopedic surgeon when they look at a child who has a slip. And there are so many new aspects to it, femoroacetabular impingement, the alignment of the epiphysis with the neck, etc., that we don't normally consider, but I think it's very important now to have a new mindset to the correct management of the slips. So any questions from the panelists?
Dr. Prasad, fantastic presentation as usual. We always look up to your presentations, and just for the benefit of other viewers who are watching this program, just highlight this Dreman sign what you're talking about, because I think many of them are not aware.
All right.
That is number one. And number two is, when you put a screw, how sure are we that the screw is not penetrating through the cartilage? So how do we make out operatively? So these are two questions.
Great. The first question about Dreman sign. Dreman sign is only another name for the obligatory external rotation deformity of the hip. So basically what you're looking for is when you flex the hip straight up without any adduction or abduction, and without any rotations actually, if you can bring it up to 90, actually forget about rotation. You try to flex the hip up without any abduction or adduction to 90 degrees and allow the leg to go whichever way it wants to go. Right, in a slip, most of the time the leg will turn, the hip will turn externally based on the deformity in the hip. So that's the degree of external rotation deformity you have. I just using a different word called FIR, flexion internal rotation, because I want to measure how much internal rotation is there, whether it's minus or even +5, +10 is not adequate in my opinion. +20 is what's healthy for a hip. So that's what I'm aiming for. That's why the FIR. But Dreman sign means you have obligatory external rotation deformity, which other people also call it axis deviation of the leg. The second point is, how sure are you about screw penetration? As you know, it's very important to keep the screw tip out of the joint, right? That's a major cause of chondrolysis. So if you go center in the epiphysis, really center, the X-ray views are pretty accurate. So the technique I use is I put my guide wire in, I park my tip of the guide wire in the subchondral bone, essentially. Subchondral bone, where what I see. And then I go, the round the world view, AP to lateral live fluoroscopy, right? And what you're looking for is called an approach withdrawal technique. Phenomenon, not technique, approach withdrawal. What you want to see is the pin getting any closer into the joint than where it was to start with, right? It will get closer. At some point, the pin will reach as close as it can to the subchondral bone and then start withdrawing. If you see that going in and out on that arc you check, then you know that the pin cannot be any deeper than where you were. If you did not get it, right, it's still approaching, it's not withdrawing yet, then you need to change your arc, change the leg or change the C-arm arc a little bit more to see that you haven't really penetrated. So you don't see the nearest point where the tip is to the subchondral bone, right? And then it should withdraw. Then you know that that's the point where it's maximally closed and it's not in the joint any further. And I maintain that angle, put my screw in, just short of my guide wire, a couple of millimeters, so that I know that that view is the closest in that particular trajectory, so my screw cannot be intraoperative. And then as a final check, you can actually take out traction, like out of the traction table, and under fluoroscopy, do a full nice range of motion, live fluoroscopy, to make sure that it's not approaching the joint.
Thank you. Jay, you have any other comments? Dr. Collin, you want to have?
Yeah, so a couple of comments. First of all, I think it's really important. One of the things you mentioned that may have been kind of slipped through, and that is that Loder's paper suggests that 47% of patients with unstable slips develop avascular necrosis. But what I tell our trainees, based on subsequent papers, is that that's the worst you can possibly do. Loder's paper shows that you can achieve rates of avascular necrosis of 47% if you do everything wrong. Which is kind of true when you look at the following papers, and indeed looking at our own historic papers when we used to do everything wrong, we matched loader. The other interesting comment that you made that I wondered about was, so my colleague Dan Perry has shown that Sufi is very much related to being overweight in that BOSS study. And it's interesting that you're seeing those two changing incidences in the United States and India. Is that because the Americans are getting lighter and the Indians are getting heavier?
I don't know if the Americans are getting lighter, but the Indians are definitely getting heavier.
Yeah. Yeah. So it's the Western diet.
Right. McDonald's.
So I leave the closing comments to Dr. Prasad.
Yeah, it's a wonderful session. We keep learning from these masters. And as Jayant said, in the beginning when we were discussing about the topics, he said that, I was just thinking that, we'll not combine too much of pediatric hip problems. We'll just confine to 3 problems. He said that, what should we give the title? He said that 3 hip problems and 3 masters. So it really turned out to be that way. And all the 3 masters really very well covered it. And thank you so much for all of your precious time. And I really appreciate Dr. Collin and Dr. Prasad for staying till the end of this meeting. And of course, Dr. Kishore Mulpuri, who did a wonderful job on DDH management, especially the initial part of it. And I immensely thank the KOA organization for giving us this opportunity. And it really turned out to be a very fruitful session. And I'm sure we can watch this webinar repeatedly. And thank Dr. Harish and Shravan, who brought out good cases, and Dr. Sagar also. Thank you one and all. I think we have consumed 2.5 hours. It's excellent. We never knew that the time just passed. And I was just looking at the time, probably, I think if the time is given, we will go on. So many things to discuss, so much to ask the masters. I'm sure one session is not enough. Thank you so much for all of you for your kind time and your precious presentations. Thank you so much.
Thank
you.
you.
We'll end the meeting, Jayant, and we will conclude this meeting. Thanks one and all.
Thank you so much, Collin and Prasad.
Thank you.
Bye-bye. Thank you. Good night.